Today, this is the meeting of the special interest group on the hepatic encephalopathy. That's as Jasmohan Bajaj sir said, this is the meeting for the flappers. So welcome everyone. We'll be starting off right on time. I'll first invite the chairpersons for the first session. Dr. R.K. Dhiman sir from SGPJ Chandigarh needs no introduction. Sir, please grace the stage with your presence. And Dr. Sunil Taneja sir from PGI Chandigarh. Welcome sir, please grace the stage. From here on in, the session is yours, sir.
Good morning everyone. So the first abstract is continuous renal replacement therapy in pediatric patients with hepatitis A virus associated ALF and advanced hepatic encephalopathy. Effect on survival. Dr. Nishant Wadhwa, please.
So good morning, respected chairpersons and members of this audience. It's indeed an honor to be here in the company of such esteemed experts. So I will be presenting this study, Continuous Renal Replacement Therapy in Pediatric Patients with HIV-associated ALF with Advanced Hepatic Encephalopathy, conducted in the Institute of Child Health, Sir Gangaram Hospital, and I'm Dr. Arjun, who will be presenting this. So continuous renal therapy is increasingly being used for non-renal indications in the ICU, and it has become particularly popular for patients of ALF with hyperammonemia and advanced encephalopathy. However, only retrospective studies are available in ALF, and even on CRRT, used in non-renal setting, the only well-conducted RCT, that is the Euphrates trial, which was conducted in patients with septic shock, did not show any survival benefit in these patients. In our pediatric ICU, we started offering patients of ALF with advanced hepatic encephalopathy the option of CRRT since 2018, and for the past 5 years, we have been doing this, and so we decided to do this study with the objective to compare the survival in these patients who received CRRT versus those who were managed with standard medical therapy, with the secondary objective to compare the effects of clinical parameters on those patients who received CRRT and to identify factors which affected survival. Obviously, it was a retrospective study, and all children who were less than 18 years with advanced encephalopathy were offered CRRT. Those who refused CRRT because of logistics issues were treated with the standard medical therapy and included as controls. Unfortunately, none could receive an LT because of logistic issues. The endpoint of the study was death, and the primary outcome was effect of CRRT on mortality. So jumping straight to the results, a total of 35 patients were included, out of which 21 received CRRT and 14 were managed by standard medical therapy. The baseline parameters of the patients in the CRRT and SMT group were comparable apart from ammonia, which was significantly higher in the CRRT group as opposed to the SMT group. Almost 33% patients in the CRRT group were fulfilling KCH criteria for liver transplantation as opposed to 21% in the SMT group. However, this was comparable. And 28% in the CRRT group also had renal indications for starting CRRT as compared to 14 patients in the SMT group. However, this was not found to be statistically significant. So coming quickly on to the primary objective. In the CRRT group, 61% survived as compared to 50% in the SMT group. However, this was not significantly different. 7-day survival in the CRRT group was 67% and was 71% in the SMT group. However, this was not significantly different. The median survival time in both the groups was also comparable. On assessing the change in parameters between the two groups, the CRRT group at 24 hours has a significantly higher ammonia value as compared to the SMT group. However, we have to keep in mind that the baseline ammonia was also higher in the SMT group. Ammonia in both the groups normalized by 72 hours. Bilirubin and inotrope requirement was comparable in both the groups after 24 hours and 7 days of therapy. On univariate analysis of parameters affecting survival, those who expired, 60% were fulfilling the KCH criteria for liver transplantation, had a significantly higher ammonia value at 72 hours and 7 days, and had a significantly higher bilirubin values at 72 hours, and inotropic requirement was also present at 3 days in those who expired. 95% of those who had failure to reduce ammonia by 30% by 72 hours also expired. On Cox regression analysis, KCH criteria fulfillment and failure to reduce ammonia by 30% at 72 hours were the only two independent predictors of mortality. Limitations. This being a retrospective study, the patient in the CRRT had a higher ammonia at baseline and had more percentage of these patients had a renal indication for CRRT. This could have led to a bias in our results. The side effects and complications of CRRT were not recorded by us, and dose of CRRT was not protocolized, so fixed dose was not followed. So conclusion, in our retrospective analysis, CRRT did not increase survival in ALF patients with advanced encephalopathy. It did not have any effect on bilirubin or inotropic requirement. However, those who had CRRT could decrease their ammonia and was comparable to those who were receiving standard medical therapy by 72 hours. KCH and failure to reduce ammonia were the predictors of mortality, and an RCT is required to assess the effect of CRRT on survival. Thank you.
Thank you. Just a question, clarification. What was your indication of the CRRT in these patients? So, and what is the point of starting actually? When did you start? Was it heterogeneous in each patient? In some you started within 48 hours and others in. So is it, yeah.
So the indication for starting CRRT was the presence of hepatic encephalopathy 3 or greater or higher. Those who were intubated because of hepatic encephalopathy were started on CRRT. The median time to CRRT initiation, I have included after my thank you slides, it was 12 hours post intubation for the neuroprotection.
That's the median. What is the range?
Yeah. The range was 100 plus minus 39 hours. My slides have been. Can you show my slides again, please?
Any other predictor of mortality?
So on multivariate analysis, only these two predictors of mortality were present. KCH, fulfillment of KCH, and failure to reduce ammonia.
Okay, thank you.
Very nice study. So I have two questions. How do you decide about extracorporeal therapies for your patients? One, and is renal dysfunction an indication to do CRT in your patients?
Yes, sir.
Yeah.
So the first question, extracorporeal therapy in ALF patients in pediatric age group, CRRT has become very popular, particularly after Akashdeep et al. Study in 2016. They showed that early initiation CRRT had a benefit on mortality. However, this was a retrospective study, and they did not compare CRRT with non-CRRT receivers. They said, and their indication for starting CRRT also included renal indications, for example, uncorrectable hyperkalemia, metabolic acidosis, fluid overload causing respiratory distress. In our study, renal indication were present in 28% of the patients who were undergoing CRRT as compared to 14% of the patients who were on SMT. Now, this can be an effect of bias, because those who were on, those who had a renal indication were obviously counseled more by the attending doctors to consider CRRT as compared to those who were not. However, this difference was not found to be statistically significant. But still, 30% of those who had a non-renal indication, that is hepatic encephalopathy 3 or 4, still had a renal indication also for starting CRRT.
So do you do plasma exchange also in your patients?
Plasma exchange, Larson et al. Study in adults has shown a survival benefit. However, there are no indications in pediatric population as of yet. No randomized controlled trial.
And if you compare hemodialysis versus CRRT, where do you get better reduction of ammonia?
CRRT hemodialysis is not indicated in ALF patients with advanced encephalopathy because of chances of raised ICP, sudden decrease in blood pressure and changes. So only CRRT is done in ALF patients.
Because of hemodynamic changes
and
which happens
yes. And even in chronic liver disease patients, the overall CRRT leads to overall greater reduction in ammonia after 2 to 3 days of therapy as compared to IST.
Sir.
So, thank you. Is this on? Yeah. My question is, this again shows that reduction in ammonia on its own may or may not make a difference. Do you think there's enough here for you to do an RCT to actually do? Because the background and these results clearly show that it doesn't work, or at least doesn't add it. Why would you want to put your eggs in that basket to actually do an RCT on this rather than doing a little more cohesive?
This is because CRRT has become very popular. Almost 90% of, according to a study, 90% of physicians in Japan will consider CRRT in ALF patients with even lesser grades of hepatic encephalopathy. So that is why it may not be useful, but still we are subjecting patients to this modality.
I mean, that you can fix that, right? You can not subject patients to them because this is an invasive procedure. It is expensive.
Yes.
It also adds a lot more, and especially where the child ultimately dies, that I can't even think about the heartache. So I think if this something doesn't work, you really should not be offering to people, especially if it's so invasive. So that's my thoughts for your plan.
Yes, sir, exactly my view. But because this procedure is so popular, 90% of people are doing it. That is why we need some conclusive RCT to refute it, to change that practice.
I think just as your point is really valid. Dr. Chetri, please.
Yeah, my contention was that you chose your patient to start CRRT at grade 3 encephalopathy plus. But if you have to really show the effect, you have to do it little early. As you correctly said, in Japan, most of them will do, 90% will do CRT at early days. If you want to show the result, whether it works or not, you select your patient and randomize it little early. Before the patient goes into grade 3, grade 4, then really nothing works. So if you have to show something works, you choose your patient and take it early encephalopathy. And then probably you will show some difference in results.
Okay, sir. Good point, sir.
The trial actually in the early phases of the course of the disease in the literature, no?
So there are no randomized controlled trials of this modality in ALF.
Any retrospective?
Retrospective have shown benefit in reducing ammonia, but not in survival.
But that doesn't translate into the survival.
Survival.
Thank you, Dr. Sir.
Okay, thank you so much.
Now I hand over the mic to Dr. Taneja. Please call the second one.
The second abstract will be presented by Dr. Tarana, and it's rifaximin alone versus combination with norfloxacin for secondary prophylaxis of SPP with HE. And this is a randomized control trial.
So, good morning, everybody. I first wish to thank INASL for giving me this opportunity to present my work. So, I am presenting my work on rifaximin alone versus combination with norfloxacin for secondary prophylaxis of spontaneous bacterial peritonitis with hepatic encephalopathy, a randomized control trial. Gut dysbiosis is a new emerging concept for complications of cirrhosis like SBP and HE. Current or recent contact with healthcare system, especially nosocomial infections, long-term norfloxacin prophylaxis, recent use of beta-lactams within last 3 months, and infections by MDR bacteria in last 6 months. These are the identified risk factors for developing multi-drug resistant organisms. Marciano et al. Had showed high prevalence of quinolone resistant and multidrug resistant bacteria in patients of spontaneous bacterial peritonitis on norfloxacin prophylaxis up to 1 year. We know that rifaximin is a semi-synthetic non-systemic oral antibiotic and has been shown to reduce oralization of gut microbiome and mucin degrading species in gut with improved gut microenvironment. It has also been shown to reduce systemic inflammation by reduction of TLR4 expression in neutrophils. So with this background, we aim to compare rifaximin alone versus combination with norfloxacin for secondary prophylaxis of patients of liver cirrhosis presenting with spontaneous bacterial peritonitis and hepatic encephalopathy both. The primary outcome of these studies were at 6 months, recurrent episodes of SBP or HE were determined. The 28, 90 day and 6 months mortality was determined. In secondary outcomes, we looked at number of rehospitalizations, new episodes of upper GI bleed and acute kidney injury, and changes in MELD and CTP scores at 6 months. This was a prospective open-label randomized control study which was conducted from September 2021 till March 2022 at a tertiary care center after ISC approval. The study was registered on CTRI. All patients of decompensated cirrhosis presenting with spontaneous bacterial peritonitis and hepatic encephalopathy both were assessed for inclusion, and after applying the exclusion criteria and sample size calculation, finally 45 patients in each group were considered. 87 patients were assessed for eligibility at admission. 17 patients had in-hospital mortality. 15 patients were excluded due to COVID-19 positive status during hospital stay and were moved to COVID-19 facility. And finally, 50 patients were randomized. 25 were allocated to group 1, which received rifaximin in the dose of 400 mg thrice daily, and 25 patients were allocated to group 2, where they received rifaximin in the dose of 400 mg TDS and norfloxacin 400 mg once daily. Finally, 25 patients in group 1 and 24 in group 2 were analyzed. Appropriate statistical analysis was performed. Among the baseline characteristics, demographic characters were comparable between group 1 and group 2. Among the clinical features, it was largely comparable. HE grade 2 and 3 were present in 18 and 6 patients in group 1 and 16 and 9 patients in group 2 respectively. None of the patients who had HE grade 4 could survive the hospital admission, so was not enrolled. And among the biochemical parameters, they were comparable, and even the liver severity score, CTP and MELD were not different between the two groups. In the primary outcome, recurrent SBP episodes at 6 months were noted in 3 patients out of 25 in group 1 and 2 out of 24 in group 2 with no significant difference. And the recurrent HE was noted in 5 patients out of 25 in group 1 and 2 patients out of 24 in group 2 with no significant difference. The mortality data at 28, 90 days and 6 months were also not significantly different. Among these secondary outcomes, the rehospitalization rate was higher in group 2. It was present in 8 patients out of 24. However, it was not different from significantly different from group 1. The new episodes of upper GI bleed and AKI were not different between two groups. There was a trend of reduction in child score and MELD score on follow-up at 6 months in both the groups with no significant difference. So these patients who had in-hospital presentation of spontaneous bacterial peritonitis as well as hepatic encephalopathy had high in-hospital mortality at presentation. The recurrence of SBP and HE at 6 months was not significantly different between the two groups. 28-day, 90-day and 6-month mortality were also comparable between these two groups. Rehospitalization rate, though higher in combination group, however, due to small sample size, could not reach statistical significance. Previous studies have also shown promising data for rifaximin use for secondary prophylaxis of SBP. The limitations of the current study are, this is a single center study. Due to COVID-19 lockdown, the enrollment was severely affected and patients were excluded due to concomitant COVID positive status. It was not a double-blind study design. Majority of patients were referred from other hospitals after intravenous antibiotic receival, as ours is a tertiary care center. So ascitic fluid cultures were largely negative. Follow-up data was only up to 6 months, and microbiological assessment of gut microbiota in terms of richness and diversity was not performed in the current study. So to conclude, patients of liver cirrhosis with SBP and HE at admission have high in-hospital mortality up to the tune of 40%, and rifaximin has similar efficacy as combination of rifaximin and norfloxacin for secondary prophylaxis of these patients presenting with both SBP as well as HE, with no reported incidence of MDRO infections after long-term rifaximin use. It should be investigated in larger clinical trials for prophylaxis. Thank you.
Thank you very much, Dr. Tarana. So I have two questions. We all know that if you use too many antibiotics in patients with cirrhosis, then there's emergence of gram-positive organisms and MDR and XDRO infections. So what was the premise of your study of combining these two drugs? And there are two formulations of rifaximin which are available. One is the 550 milligrams and the 400 milligrams. How did you decide about this 400 milligrams TDS dose in your patients?
Yes, sir. Sir, the idea of conducting this study is when a patient is presenting with spontaneous bacterial peritonitis in hospital, the presenting symptom may be abdominal pain, shock, fever, and then hepatic encephalopathy is a very important clinical presentation of patients with SBP. And also infections are a precipitant for hepatic encephalopathy. So we conducted this study in the special group of patients where SBP patients had HE on admissions. And then when we discharge this complicated group of patients, we have to put them on double antibiotic prophylaxis. For SBP, we put them on norfloxacin, and for HE, we put them on rifaximin and lactulose therapy. Because of the emergence of MDRO infections after long-term antibiotic use, it was thought that if rifaximin has been shown in previous studies, it has been actually investigated for secondary prophylaxis of SBP. So we chose this complicated group. Whether rifaximin will work for both of them, it will cover the SBP as well as the HE part, so that we can reduce at least prescription from one antibiotic like norfloxacin. And the second thing, it was available in-house in hospital at 400 milligram dose. So we chose the rifaximin 400 milligram oral preparation.
Any more questions, comments?
How did you decide that at the end of the therapy or end of the follow-up of 6 months, that fellow did not have SBP? Patient may not have symptom of SBP, but to see that your drug is effective, you need to show that the end of the observation period, the disease did not occur. In your study design, is it figuring that at the end of the study, you checked for appearance of SBP or not?
No, sir,
that was not included in the study.
Sir, we did not.
You just followed the symptom, and at the end of the follow-up, if there was no symptom, you decided that there is no SBP.
Sir, even in the best of the guidelines, they do not say that once we document.
Yeah. Talking about clinical measurement is different, but study design is different.
Yes, sir.
That's
the main limitation is sample size actually.
Yes.
That you did not mention. Because if you see recurrence of encephalopathy, it was 5 of 25 versus 2 of 24, means 20% versus 8%. If sample size would have been proper, I think 20% to 8% would have been statistically significant.
Sir, I do agree with you. Actually, this study was stuck in COVID-19 positive era, so we really were stuck hard because of the enrollments, and 15 enrollments were lost because of the positive status of the patients.
Beyond March 22, no? You would have extended the study because you stopped the study in March 22. You could have further extended for 6 months and seen the more patients.
So the IC approval was off, sir. It was actually approved for 1 year, and so that period was getting off. So the primary, the resident who was working on this had, the tenure ending by that time, and IC approval was not extended beyond that period.
I think in India, most of the hospitals, they prefer lactulose.
Yes, sir.
And probably most of your patient probably has taken lactulose.
Yes,
so
sir.
how many patients in the both group are taking lactulose simultaneously for the prophylaxis of SBP for HE?
Sir, lactulose was prescribed on the regular basis to all the patients. It was including.
I think the title of your study should be combination of lactulose, rifaximin, and norfloxacin versus lactulose, because you are missing something which is very important for secondary prophylaxis, the lactulose. So on the title itself, we should come up that most of the patient, would be 100 of the patient, they were taking lactulose also. Because we are not sure whether lactulose or rifaximin versus lactulose alone is more efficacious. So the title should be, I think, it should be different, and it should be combination of 3 things.
Sir, pardon, but we were actually seeing the response of rifaximin on the.
Agree, but all the patients were on lactulose, which has its effects on prophylaxis of secondary HE. So I think the combination should be the better one.
Yes, sir.
If there are no more questions, thank you very much. We close this session.
Thank you.
With a wonderful discussion and wisdom from the world over. Now, invite you for the meet the expert session for the day, which will be the experts. Can I have them on stage, sir? It's my honor to invite already Sunil Taneja sir and Diman sir are here with us on stage. I invite respected Dr. Jasmohan Bajaj sir, who's come all the way. Please raise the stage, sir, with your presence. And it's my honor to invite Dr. Brajesh Chandra Sarma sir to please join us on stage. The session will be moderated by Sunil Taneja sir. It's a case-based discussion on hepatic encephalopathy. The stage is yours, sir. And excuse me, I call Kamal Chetri sir, Baldev Rana sir to grace the first row as the panelists. Praveen Sharma sir. Subdeep Chatterjee sir. I can't see him here. And VM Dayal sir. You can join us. So I'll place one more chair.
Yeah, sure.
Please join us on stage, sir. I'll.
Give the mic. Good morning, everyone. So I'm going to present a real-life clinical scenario today. Can we have the residents in front, because it's for you? It's going to be a real-life case and how to manage a patient of hepatic encephalopathy. Residents, can you please come in front? Okay, so there are a lot of debate which is going on. What drugs to use in patients with hepatic encephalopathy? Should we use combination of drugs? How do you classify patients who could present with HE in your outpatient? So few questions in this which needs to be discussed, especially for the residents. And I'm going to quickly take you through this case, and then questions first to the audience, then to the panelists, and then final verdict by the experts. Okay, so this is a 51-year male patient. He was a diabetic for 15 years and was on insulin for 2 years, hypertensive. And he just presented with recurrent episodes of altered behavior. This was some irrelevant talking, episodes of drowsiness, sleep disturbance, and he developed 6 episodes over the last 8 months. On examination, he had flaps. BMI was 27. He was obese. Vitals were stable. No stigmata of chronic liver disease. The liver was palpable 1 centimeter below costal margin, and there was splenomegaly. Okay, so let's look at the investigations. Platelets were on the lower side. INR was normal. Creat was normal. Bilirubin was 0.5. AST was 50. ALT was 48. And protein was 3.6. So he underwent an ultrasound examination that showed features of cirrhosis with portal hypertension. The serum ammonia came out to be 296, and CT head was normal in this patient. These are the etiological workup. This is the etiological workup of this patient. Viral markers, autoimmune, iron studies, all was normal. TTC was negative, ceruloplasmin was normal. Endoscopy showed grade 2 varices. There was mild portal hypertensive gastropathy, and fibroscan showed a LSM value of 56. So the provisional diagnosis in this patient was probably NASH-related cirrhosis, what we call now MASLD, and decompensated. The only decompensation in this patient was hepatic NCEF, and he would fit into CTPB and MEL score of 7. So let me just ask the residents first, how do you classify HE? And where would you fit into this patient? Anybody? You can take the mic. Anybody who wants to take this question?
We can classify along various axes, whether it's whether there was an inciting factor or not, whether it's a recurrent or the first episode, sir. Then according to the
Okay, so let's go to the experts. In your real life clinical practice, which you see in OPD, what is how do you classify this patient? You just label him as recurrent HE, or you want to do better classifications, use some other classification?
The first thing is, I think we should classify whether patient has an covert HE or patient has an overt HE. This is how I practice in my day-to-day life. Then whether patient has an acute episode, as the classification says, A, B, C, which we know. A for acute liver failure, B for patient has some shunt, and C for patient has cirrhosis. Then we say whether patient has some precipitating factor, patient do not have some precipitating factor, or patient has, it is an episodic or it is persistent. When we say this patient has 6 episodes in the last 8 months, so this patient has probably recurrent HE, but we do not know in between whether the patient remains out of HE or not. So whether it is a persistent HE with intermittent fluctuations which has converted into an overt HE, or patient has a maybe recurrent in between the patient is absolutely all right. So this has to be seen by the the clinician whether the patient is perfectly out of HE, that is the overt HE patient has, or in between patient has a covert HE also.
Yeah, this is very important. The recurrent part is so important because it's quite likely that this patient has been going through this, and only at retrospect, the person encountered someone, their family members realize that this has been going on for a while. It's a really scary thing, and I think the reason why we built that into the guidelines is to make sure that people realize that recurrent is kind of a very important part, and if you don't fix it now, and if you don't dig deeper and find out what the precipitating factor is, most likely that precipitating factor is going to come back again and again and get worse over time, and the patient gets more sarcopenic, more tendency towards have falls. The one thing in the labs that I found was a little unusual, the albumin was actually quite normal.
Preserved, yeah.
And there's a lot more shunting, it seems like, and a lot less liver failure. Would you...
Dr. Sharma,
is this something that you're going to
One
do later?
thing, recurrent episodes altered sensorium in 8 months. Before labeling it as hepatic encephalopathy, I would like to have details of recurrent episodes and how much time it has recovered. You see, patient is 51-year-old, diabetes and hypertensive. And in that case, though blood ammonia is high, LFT is almost normal, bilirubin normal, albumin normal.
Yeah.
Therefore, I have a strong doubt on hepatic encephalopathy unless or until I do CT scan and I show a large spontaneous shunt. If I fail to show large spontaneous shunt, I say it is not hepatic encephalopathy at all. I will say about TIA, transient ischemic attack, which are recovering in 24 hours.
Sir,
But if you show spontaneous shunt, then I agree.
Sir, 6 episodes of TIs, I would not take that by that, but yes, obviously you need to exclude all other causes before you label a patient with HE.
So it may be possible that he has recurrent
diabetes,
hypoglycemia.
hypertensive patient, albumin 3.6.
Yeah.
No ascites.
Yeah, no situs.
More fit into hypoglycemia, sir.
So this is...
Hypoglycemia,
Yeah,
I
I
agree.
totally agree.
But TIA can also occur within
Yes,
24
I
hours. This recurrent TIA is known. 6 episodes in 8 months of TIA is not odd. It occurs. And in a patient with ascites, no ascites, normal albumin, and no spontaneous shunt, I totally disagree with hepatic encephalopathy.
Okay, so...
what you can say is we have insufficient information now
information.
to include or exclude. You can't. But what I meant is, what is this guy's family support like? 8 times this guy is confused
So,
in 8.
yeah.
They're like, oh, he's like this. He's not like
No.
80. He's
Yeah.
like 51.
Now, the issue was that he was coming to the emergency, getting admitted for 24 hours, and then being discharged from the emergency.
Can I have
Okay, so yes. So in and out of the hospital, and
can I
Sir,
have
please.
my point actually?
yes, sir, please.
Once you have the 8 episodes of altered sensorium, along with the flaps also, may I know how did you treat these patients? Did you use the anti-ammonia or the anti-hepatic encephalopathy measurement, or have you noticed that it was a hypoglycemic episode? It is not a single episode.
Yes, sir.
Say there are the 8 episodes. I think कोई इतनी खराब नहीं हो सकती है किसी की clinical sense that he cannot diagnose hypoglycemia during the 8 episodes. Therefore, I would say that we have to understand as a liver specialist also, whenever you are having a near normal or slightly abnormal liver function test, in the presence of the cirrhosis of liver, you must search for the shunts. That is the message actually, clear cut. Rather than debating these episodes or the hypoglycemia or the TIA, you have to see that how did you manage these episodes also. I think that is equally important.
Sir, please.
As Dr. Bajaj said, and then Dr. Dhiman said, I again repeat, a 51-year-old diabetic hypertensive, no jaundice, no ascites, albumin 3.6, no spontaneous shunt, and recurrent episodes of altered sensorium
So I'll show you what happened in this case. So there is more to this.
Episodes in 8 months, they are against overt encephalopathy also.
So
But I think
If there are no spontaneous
the
shocks.
latest
Yes,
NASH
sir.
CRN thing showed that the first episode could be encephalopathy, first decompensating event. Let's
Yes.
move on.
Yeah. So obviously, first he was seen by the neurologist, the first episode when he came in the EM, emergency OPD, and then by the physician. A lot of people saw him. Since he improved very quickly after getting some form of treatment in the emergency only, he was discharged. Then he came to us. Anyways, so he had these episodes of altered sensorium. That is clear. He had flaps at presentation when he came to us, and he was diagnosed with hepatic encephalopathy. So this is what we have already discussed. I think the message here is you have to see the patient in totality, and there are implications how you label that patient, whether it's the first episode of HE or it's recurrent or persistent, and this is the classification which has been suggested. So as Dr. Bajaj has said, it is very important to label that this patient had recurrent episodes of HE, and we have to find out the cause of recurrent HE and treat if possible. So let's go forward, and let me just ask the residents here. Now you have this real life patient. He's coming to you, and he's had 6 episodes. How will you treat his encephalopathy? Anybody wants to take this? Yeah, please come here.
Lactulose plus rifaximin, and we'll get a CT abdomen to rule out any shunt.
Okay, so you want to do a CT abdomen, and you'll give rifaximin plus lactulose both.
Yes.
Okay, anybody else? Sir, please.
I would also add Lola. If the patient had 8 episodes of encephalopathy, I would also add that.
So lactulose, rifaximin plus Lola?
Lola.
Okay. Dr. Baldev, what is your thought on this?
History will be important in this patient. Maybe this patient is dependent and he is not taking medicine. Maybe he's coming, he's treated, he leaves his medicine, again he comes in the encephalopathy. Maybe that is there. But I go with lactulose and rifaximin.
Dr. Shetty, please.
Yes. So adherence to the treatment that you have given, or whether the drug was taken as advised or not, that is a very important part to be checked, because the drug's supposed to work, and there is no reason that it's failed so many times.
So there were some issues with compliance in this patient. Dr. Praveen, what is the evidence to use all these 3 combinations? Dr. Chetri wants to use lactulose, rifaximin, Lola in this patient, all 3 together.
If you go by the evidence, I think the only evidence which we have is combination is still okay, lactulose and rifaximin, which can be used for the prophylaxis of HE if the patient has not been responding to lactulose and patient has an episode, then add on rifaximin. We have some evidence. But if you go by the practice things, most of the physicians, most of the hepatologists, I think if the patient has come to any one of us, most of us, we will rule out whether the adherence of the drug is there, we will rule out whether the shunt is there. But if that is not the scenario, I think most of us will prefer combination of all the drugs which are available. So there is no evidence on literature based on combination of all the 3. 2, lactulose and rifaximin, we have evidence for prophylaxis.
Let's ask the experts. Sir, what is your thought?
D, lactulose plus rifaximin, because of the grade A evidence for that. Assuming, like Dr. Sharma said, that this is HE, it looks like it, but again, what we need to figure out what the adherence was, why this patient was. What we do in our practice is, because Lola is obviously in the United States, it's not approved. Rifaximin, they have to have at least 2 episodes. Now, what do you mean by 2 episodes? So if you have a patient who goes at home and occasionally for 5 minutes goes like this, and then that's not considered an episode. The episode has to be witnessed by a medical provider. Can be a nurse, can be a physician assistant, can be a nurse practitioner, can be someone in the ER. Someone in the emergency room, someone says this person has altered mental status, is disoriented, has asterisks, whatever. That is considered a medical episode. So it seems like from your analysis that the person had some kind of medical contact, and it was not the caregiver saying that this person had something, I gave them lactulose and they got better. That for most trials, etc., would not be considered.
Okay.
So in this person, because rifaximin in the US is so expensive, you have to justify the failure of lactulose. So as Praveen also pointed out, this is a failure of lactulose. If they were given lactulose, for whatever reason, they were not taking it, they could not tolerate it, they took too much, or things were just not clicking. Then you add rifaximin, that has the strongest evidence-based. Now, evidence-based versus what is done in practice is dependent on what you have available, what is the patient can afford, and how much you've actually told the patient. So in my practice, this person would be a candidate for lactulose and rifaximin, but I would have had to document to my insurance people, everyone, that they, in these multiple ER visits, lactulose was given, and lactulose, for whatever reason, was not tolerated. So effectiveness of the therapy rather than the efficacy of the therapy. Efficacy means you, in a trial, you give a drug and the trial, but where in the real world, if the drug, for whatever reason, compliance, cost, patient tolerance, or just lack of education, means that the drug is not taking, which the effectiveness is low. So it seems like the effectiveness of lactulose in this patient was low for whatever reason. And therefore, addition of rifaximin would be, an important step in my practice.
So, what is the appropriate dose of rifaximin which you would recommend and lactulose in
So the
such a
only
patient?
dose we have for rifaximin is 550 mg BID in the US, and that is, they did a new formulation. There's really not, the only thing is, the adherence is better if you have 2 versus 3, especially if you're talking about a lifelong therapy, therapy until the patient gets a transplant at least. So less is more, and the studies that they had done was 1200 was similar pharmaceutically to 1100. Now lactulose dose, I get, especially since we actually did the research on the Bristol stool scale, etc., I've become a little more lax. I don't insist that patients get 2 to 3 bowel movements a day. They just have to have softer bowel movements and not very soft. And they become, we have an app also that they actually can take pictures. It's a poster at ACG. So basically the patients now take a picture of their poop, send it to an AI thing, and they actually calculate the Bristol stool scale for them. But the disgusting part is they still have to look at their poop, and a computer looks at it. But we don't do the app regularly, but we've trained our patients so much that they become the masters of their own destiny, rather than 2 to 3. And it becomes very challenging because everyone has their own bulb. So I make sure that they're not constipated. That's what I insist. And after that, if they are it becomes very individualized. So my thing with lactulose is it's a very cheap drug in the US, but it's very expensive when it comes to human resources. You have to spend a lot more time explaining to the patient, at least in the Western countries, I don't know what Punita thinks, on how to use it, how not to use it. And the most calls that you get afterwards, at least in Western countries, are for lactulose adherence, non-adherence, too much working, too little working. So at least in Western countries, lactulose, I've stepped away from 2 to 3 bowel movements. I just want to make sure they don't get constipated. And if that doesn't work, then I have a low threshold of starting rifaximin. But again, that's in our sphere.
Yeah. So message here is that lactulose remains the first drug of choice, and rifaximin can be added if it is not improving. So let me go to Dr. Dhiman. So what is your practice?
What I'm saying, not can be, it has to be added.
Okay.
Because if there is a breakthrough episode of the HE while on lactulose, then you have to add the rifaximin. That is as per the recommendations, the ASLD as well as the European also. But the only thing is that if something is, a person is going to have the repeated episode, even if on the 2 drugs also, then you have to look for the other regions also. That is very, very important. And one more thing I will say, that a little bit disagreement with the judge. The lactulose dose, we Indians tolerate the lactulose very well, actually, and we have the comparative study with the US population, with the Indians also. While the US population, they have the problems, but the Indians are very much happy. So our directions are usually 2 to 3 semi-soft stools per day.
Dr. Sharma, please.
From my side, treatment is very clear. First step, CT for spontaneation. Second step, for treatment as well as prevention of recurrence, first drug of choice to me is lactulose. Rifaximin is added or alternative depending upon the clinical condition. Depending on the clinical condition,
So
rifaximin is added or alternative.
you will add rifaximin in this patient?
I will start with lactulose. I am satisfied he is having 3 to 4 motions per day and he is responding, I am happy. If in spite of dose 3 to 4 motions per day, not responding, as Professor Dhiman said, I will start rifaximin also. I will start combination.
And you have Lola available in India. Where
Lola
is the
has been
indication of
used
using Lola?
only for treatment of hepatic encephalopathy in combination with lactose rifaximin, number one. Number two condition, it has only been tried in advanced grades of encephalopathy, grade 3 and 4. In this patient, we did not know about the grade of encephalopathy. And second thing, Lola, can be given, then again it is added or alternative, but only in advanced grades of encephalopathy. It not only improves encephalopathy better, it improves the survival also.
Dr. Dhiman, your thoughts on Lola? Will you try Lola in this patient or just rifaximin and lactulose? Dhiman, sir.
Sorry.
Very insufficient evidence so far about the Lola, except the one good study that is published in hepatology, and that was used in grade 3 and 4. Rest of these studies which have come from the Germany, particularly the Karkais group, they are not very convincing. I will not add the Lola at all.
Yeah, the oral formulation is not very well. The evidence is not there, either for minimal or covert or whatever you want. But the IV formulation, as Dr. Sharma mentioned, has a much stronger grade of evidence. But it's not for recurrence. It's not for this person.
One clarification. German studies, Kaichis et al., Lola, are in MHE or low grade encephalopathy. In advanced grades of encephalopathy, we have two studies from India. One we did in collaboration with Dr. Sidhu from DMC, and second we did independently. Both groups have shown in advanced grade of encephalopathy, if we add intravenous Lola, it is helpful in improving grades of encephalopathy.
Okay, message here is clear. No role of Lola in such patients. So let's just go forward.
Dr. Sunil,
Dr. Praveen, sir, please.
Sir, I'm not against the evidence, which is not there for the Lola for the management. So management part, we can give Lola. But there are many patients in whom they have a low-grade HE, maybe low-grade in the sense, they feel like they are having altered sensorium. The relatives themselves, they give Lola at home, and most of the time they can, overcome the overt HE. And this is not it is a real-time scenario, sir. There are a number of patients of us whom say that on telephonic discussion, they have some altered sensorium, they take Lola at home, and they are perfectly all right. Though we do not have evidence based on RCT, based on other evidence, but most of us, I think, we have experienced such type of patient that they feel better even at home if they take Lola at home.
Praveen, I don't have any experience actually because I am not convinced. So your things about you is okay, but cannot be generalized.
I totally agree. So I'm not saying there are evidence for it, but there are a number of patients who feel better at home.
Yeah, but this is an art and science. You know your patients' relatives know your patients. So whatever works, as long as it's not harming the patient. The question is, you don't want to give them extra cost because this is already a very expensive disease. For something that doesn't work, it's really something that you must think twice. And if it works for the patient, it works.
The only issue was eight time getting admitted.
Yes.
8 time patient coming with the same complaint again and again.
So emergencies
and
the
same medicine again and again.
The kind of rush we have.
How do you manage such situation?
One thing very clear. As Dr. Praveen said, in clinical practice, it helps. There is no much evidence. I disagree. In clinical practice, it helps, but there is enough evidence also. If you see studies from India, studies from Butterworth, there are 3-4 studies from Butterworth only, which has shown that multiple, other than lowering effect, hepatic regeneration, hepatoprotective, anti-inflammatory, even neuroinflammation it inhibits. It has been shown to be multiple mechanisms of action, and in most 3-4 randomized controlled trials, it has been shown to be effective alone in low-grade encephalopathy.
So I think,
I differ in this. Lola is not to be given. I think even some people say in low-grade encephalopathy, Lola, like lactulose rifaximin, may be a first-line therapy also.
So I think we won't agree to this, and we need more evidence before we can suggest that Lola should be used in certain.
So Sunil, one very important thing that we are missing here is the lack of. We focus too much on the drugs, but what happened in your system, and it happens in the US also. It happens in every system. That a person came to the ER 8 times with confusion, was not linked up until the 8th time with a hepatologist. Yeah. What happened? That's, if you look at the checklist that we give our patients at discharge, out of the 8 things that we give, 5 things have nothing to do with medicine. They all have to do with, do you know who your doctor is? Does your family member know what the symptoms of HE are going to be? Do you have your drug in hand? do you know how to take this drug? It is all pharmaceutical nurse step life questions, because those are the ones that actually prevent episodes, not really these drugs. And we can argue amongst all of us about Lola versus yes. But if the person does not know who that doctor is, they are going to come back.
So let me tell you, like, this patient was first seen by the neurologist, put on anti-epileptics also. You know, in the ER, he came in the ER, CT had normal, altered sensorium, could be a seizure, you get an EEG and come back again. So that's how this case proceeded. Anyways, let's go forward. We just have 6 minutes. I'll just, so I think the evidence for Lola is not sufficient. Yes, it's being used in clinical practice by some physicians, but we need more evidence. So quickly now, role of branched-chain amino acids. Sir, Dr. Chetri, branched-chain amino acids. We have to just sort it out. 6 minutes left.
So because of the cost and thing, experience of using branched-chain amino acids is very, very less. So in practice, we don't use, but there are some evidence that it does work, but I am not very sure.
Dr. Praveen, your thoughts on branched-chain amino acids? It's readily available. It's being used by a lot of physicians in India.
I do not normally prescribe branched-chain amino acid to my patients.
So no branched-chain amino acids. Dr. Dhiman? You like a lot of branched-chain acids?
No branched-chain amino acid, particularly in this patient where the liver function are fairly preserved here. That's what I'm
saying. Where is the indication to use branched-chain amino acids? Should we use branched-chain amino acids or no to branched-chain amino acids in patients with cirrhosis?
We don't know what is the exact cause of the recurrent hepatic encephalopathy. That is the one thing. Once we exclude out that it is not a shunt over here and it is all liver, then there is a role of the BCCA. But the problem over here is that it is only the what is the MELD score 7 and the child is the B. Actually, according to condition of the patient that we can use. I think
in your clinical practice, do you recommend using branched-chain amino acids?
Huh?
In your clinical practice, do you use branched-chain amino acids in any group of patients with cirrhosis?
Yes,
I
use.
Where, sir?
They are basically the decompensated cirrhosis of liver, and you know that the BCAA metabolism is through the muscles also. In those persons, I particularly use, I add on the BCCA 5 grams twice.
Sarcopenic and failed patients, that's what you want to say. Dr. Bajaj, your thoughts on BCAA?
I don't use it. It's not available in pharmaceutical grade in the US. Now, patients do want to go to the nutrition store and get it. I don't stop them. But since you have less time.
Yeah, let's go to the probiotics quickly. One question. Probiotics. Everybody uses probiotics.
Please, why do you ask protein restriction? Yeah, probiotics, again, for the same reason for branched-chain amino acids in the US, they're not pharmaceutical grade. They can be whatever. So the only way I give them probiotics, which is really like the way to do it, is yogurt. Yogurt in the US has to have live and active cultures. And I ask them to eat Greek yogurt, the full fat Greek yogurt with high protein, which fills them up mostly at night, pack a snack, as Dr. Dunton mentions. And this is something that I give. I ask them to change their diet a little bit. So, but it's more of an addition.
Just a small comment. I'll come to you, Dr. Dhiman. Let's ask the house first. How many of you use probiotics in patients with HE? Okay, so as a routine, no use of probiotics. Final verdict, sir.
I just want to tell that we have conducted one study that is published in Gastroenterology. The patients, high-grade encephalopathy who recovered, discharged, in those patients, we have randomized, blind randomization, the probiotic, and particularly we have used the VSL3, which has more than 100 billion bacteria, as a good one. And they have demonstrated not only the inflammatory markers goes down.
So would you recommend using probiotics in such patients?
If somebody is having the bad liver functions and recurrent episodes of the HE, definitely
in decompensated cirrhosis.
This is in my particular clinical practice where I am using the BCAA as well as.
So not as a routine, but yes, in decompensated cirrhosis, you would suggest that it can be used. Dr. Sharma, last quick comment. We have 2 minutes.
Small, 2 lines only. For prevention of recurrence of encephalopathy, probiotics we use in clinical practice and have been found to be as effective as lactulose for prevention of recurrence. And secondly, Dr. Bajaj said probiotics they are not using because it's not approved in US. Because it's approved in India, so we are using it. Yogurt he is using with basis of probiotics only in the back of
No, sir, I am getting confused. We have 2 minutes. Are we suggesting that we should use probiotics in such patients?
In prevention of recurrence, yes.
He has multiple episodes of HE.
Yes.
So you want to add probiotic to this prescription now?
No.
Yeah. If there is no shunt, why not?
So, okay, the reason why not is for a couple of reasons. I do not know what the grade of probiotics you have here, but in the US, they can have 0 colony forming units. They'll charge the patient the same amount of dollars, because if it's not done from a pharmaceutical grade. Now, there are certain pharmaceutical grade probiotics like Saccharomyces cerevisiae for inflammatory bowel disease, but they are not the same as the Visbiome, which is the
Okay, so still debatable. We can have a discussion later.
Probiotics can actually cause lactobacillus hepatic abscess.
So we can discuss later. I have 2 more questions to discuss.
That is a practical problem in US.
No,
Here in India.
Okay, sir, we can discuss later. I have 2 more questions.
But there's also these probiotics are not benign. Lactobacillus SBP, lactobacillus septicemia do happen in devitalized patients. So you got to be very careful when you say blanket statements like instead of lactulose based on one trial, which is open label.
Okay, so let's go forward. Let's go forward and diet recommendations for such a patient. Diet. Quick one diet recommendation. What you would suggest to such a patient? Diet.
You're not going to change anyone's diet.
No diet change?
You can
vegetable protein.
You can try what you want. They're not going to change their diet. All you have to tell them is make sure do not restrict protein and ensure that whatever you want to give, you have to be a realist.
Yeah.
You certainly can't afford get someone who's a non-vegetarian to stop eating
Message
meat.
here is no change in diet, no restriction of protein.
That's no restriction of protein. No, the change of diet is as much as they can do.
Yeah.
For example, we just have an oral presentation at INASL in which we replaced one in the Western non-vegetarian meal with vegetarian, and that reduced the ammonia levels. That was enough. Now we're doing a larger study to find out whether just substitution of 1 or 2 meals might be better. And that may be a more attainable goal than just telling a non-vegetarian to suddenly change into a vegetarian.
So in India, most of the people would have a vegetarian diet. Dr. Dhiman, your comments, quick one comment only.
I would say we don't change much as far as the diet is concerned. They only say that the protein should be increased also. In addition, what I say that I don't even restrict the fat in these patients.
Okay. So short comment, sir.
Vegetable protein better than animal protein already been shown. We have done 3 nutritional studies in encephalopathy. In all the studies, we prescribed vegetable protein diet, not a non-vegetable. And there are already studies which have shown that vegetable protein diet is better than animal protein diet in encephalopathy.
Okay. So Dr. Praveen for the last comment.
Sir, as far as Indian people are concerned, if we are saying they are non-vegetarian, almost all are vegetarian. Whatever non-veg they are taking, this is almost negligible. So I think we should not change the Indian diet. Whatever they are taking, we should continue with the same diet.
And just a last comment from my side. Many of my patients, they take chicken, they take fish. I don't stop it actually.
Yes, I think
only thing I say that don't take the red meat. That's all.
Okay, so diet part is clear. Now let me show this patient what this patient had. These are the axial CT scans of this patient. Recanalized large paraumbilical one, the black arrow, and multiple collaterals. These are the sagittal and the coronal sections. Oh, there's a big, this paraumbilical, patent paraumbilical vein, and it's going and opening into the right iliac vein. And this is the Doppler in this patient. Flow was there. And how do you manage this? Just one quick question. Block this shunt. Yes. So what we did in this patient. Yes. This was.
There is some disagreeing. This thing. If patient responds to lactulose or rifaximin, no recurrence of encephalopathy, I will not block the shunt.
Sir, 8 episodes, you will block the shunt? No.
Whether he had medical treatment or not, that
he's got that. He's got that.
The treatment. Yeah, that was not clear. He got lactulose, rifaximin, what the dose, what are this thing. If he has received medical treatment,
yes, sir.
Then encephalopathy recurred, I agree.
You would block that. That's what we are trying to say. Yes. If it's not improving with medical management, you should block the shunt. Okay.
Sunil, there are the 3 things in this patient. Ammonia is higher, and he is not responding to the medical therapy also. And the CTP score is only the B also. It is an ideal candidate to block the shunt. MELD is less than 11.
Yeah, so there was a high flow shunt. This is what we've done. Sir, I think we have to close now.
Just one thing, for blockage of shunt, always recommendation is if patient is not responding to medical therapy.
Yes, sir. Yes, sir. Agreed. No. That point is well taken. So there was a high flow shunt in this patient, and this was blocked with glue. Complete obliteration of this shunt, and you can see the glue in this patent paraumbilical vein. The ammonia came down, and I'm going to skip all this. So let me just quickly wind up now. And this is what is recommended. or if the liver functions are good, you've medically treated the patient. If they're not responding, if there's a portosystemic shunt, you should block it. So I'm going to close here. Thank you very much for being here. And I think this debate will continue and we can carry forward during the tea break. Thank you so much. Thank you all the panelists and the chairpersons and the experts and all the delegates. Thank you so much.
Wow, what a stimulating discussion this morning. The experts, and I thank all the experts who came all the way. Thank you, sirs. I thank the panelists and I thank the delegates. We now move on. We have organized a workshop for healthy liver among children. I request all to settle down. Welcome, welcome, boys and girls. Welcome, boys and girls. Good morning. Thank you for taking time out. Let's all settle down now. Yes, take your seats. It's so refreshing to see smiling young faces. So, ladies and gentlemen, boys and girls, children of all ages, have a seat, find your seat, settle down. We have a small workshop here, which will be an interactive workshop. You can take the chairs in front, please, don't be shy. There's a lot of chairs in front, young boys. Don't be shy, there are chairs in the front. This program is for you. It's so refreshing to see all of you. I hope all of you didn't have too much trouble. We are honored by your presence. You are the future. You are the future. So please settle down, find your seats. We have experts here who are going to talk to you. And this is for children of all ages, not just you boys and girls. All right, quiet down now. Yes, the boys at the back benches. There's a row here. You can fill it up. Yes, yes, find your friends, but not too much chatter now. Find your friends. Right, now I need you to have some silence. Thank you all for joining us. Good morning. Namaskar. It's my honor and privilege to host this workshop for you. My name is Dr. Rajat. Good morning, everyone. Can you have a good morning? Oh, thank you, thank you. Josh is quite high. This is quite refreshing. You know, seeing all these gray-haired oldies. Now it's so refreshing to see all of you smiling. Everybody had their breakfast? Yes. That's the reason for the Josh. That's so great. That's so great. Let's have some silence. Now I'll call Dr. Manas sir, Dr. Manas Panigrahi sir, to say some introductory words and invite our guests onto stage. I have a galaxy of luminaries here in front of me from all corners of India and from all corners of the world, I can say. Manas sir, stage is yours.
So thank you, Rajat. Very good morning to all. Great. So lively audience, na? So today we have a program, liver workshop. You know liver? Everybody? How many liver we have? Great. So today we'll interact, we'll have some knowledge about liver, how liver works, how we have to take care of liver, what is the importance of liver in our life. Okay. So basically, this is purely informal meeting. We'll interact more. We'll ask. You will ask any sort of doubt, question to us, and we'll have a formal introductory meeting. Will be there. One presentation will be there by our chief speaker. We have lot of dignitaries from outside, and we'll interact more. Okay. So first of all, the concept of this liver workshop, who has organized, and our organizing secretary, Dr. Manoj Sahu, I want Dr. Manoj Sahu to be here to have a words with you.
So a warm welcome to everybody. So this is INASL, Indian National Association for Study of Liver. The 31st annual meeting is going on at Bhubaneswar. We are very fortunate that Odisha is holding the meeting. So with a special invitation, you are here. We are grateful to you. So I am grateful to Bharat Scouts and Guides. So before starting the program, I think I'll request someone from Bharat Scouts and Guides, Mihir Babu or someone can come to the stage. Madam, asiye madam. Asun, jail jana asun. So I want somebody to just tell a little bit about Bharat Scouts and Guides. Kia sive, asun kia sive, please come. Please come, please come. Can you tell a little bit about Bharat Scouts and Guides? Who is there? Okay. So all the children, so we were very excited. I'll tell you something. If you see the proportion of young people in India, the proportion of young people in Odisha is the highest if you compare with any country across the world, including China. So this is our strength. The purpose of doing this workshop is only one intention, that liver is extremely important. We have one liver, as you told very rightly, and we have one life. If you want to lead this life very effectively, very positively, with a good purpose, with a healthy life, we have only one choice. We need to keep our liver healthy. And liver does more than 500 works continuously to keep us healthy. So it is our responsibility to pay attention to the liver. So we need to keep our liver healthy if you want to lead a very purposeful, healthy life. What Corona taught us, Corona taught a beautiful lesson to us. There are many challenges expected in our life. Many problems are expected in our life. The only way to go forward, only way to face all the challenges in our life, if we are healthy. To keep ourselves healthy, we need to keep our liver healthy. Can I request somebody from Bharat Scouts and Guides? Madam, please come. You are welcome here. We have international faculties, so very eminent people. So that is the way to put salute like here. Okay. Can you...
Scout Guide class go.
Can you have a one second? Can you have a Scout Guide class go for our international faculty?
Scout Guide class go.
Thank you very much.
Good morning, everybody. Good morning, everybody. Good morning. Scout Guide class go. You all are welcome to this auspicious occasion. So, Bharat Scouts and Guides, it is a international organization and it is a non-government organization. And our organization is all over world, not only in India but all over the world. And the children starting from the LKG to till the end of their life, they can join in this worldwide organization. And in this organization, we teach the children to serve the nation, to help other people and care the nature around us. The trees are our friends, animals and birds are our friends, and our motto is be prepared. It means physically strong, mentally awake, and morally straight. We all are friends. When we are meeting each other, we are giving this sign. This is our Bharat Scouts and Guide sign. And we, the children, are from Odisha State Bharat Scouts and Guides. Dr. Kali Prasad Misra is our State Chief Commissioner as well as National Vice President. So all of you give a clap to our State Chief Commissioner. Class, Scout, Guide, claps, go! From the very beginning, from the childhood, we the children are taking to this organization from the LKG to standard 5, they are called as Bunny. Then up to standard 6 to standard 10, they are called as Scouts and Guides. The boys are called as Scouts and the girls are called as Guide. We are having our own uniform. That is the uniform. This uniform, all over the world, the uniform is same. For different level, the Bunny, Scout and Guides, then after the school, that is 11th class, that is the college, they are called as Rovers and Rangers. They are also having their own uniform. But this uniform, if I will wear this uniform and I will go across our country, means apart from India, whichever country I will go, if they are also including this Scout and Guide department or this organization, they can recognize me and immediately I will come to their place or they will come to my place, and we are having the left handshake. Left handshake means we are having the heart in our left side and we are meeting with each other with our heart. This is called the left handshake. So in this organization, we are not only learning to serve others or to serve the nation, but also we learn the thing how to be a national leader or how to be a leader to serve the nation. So again, my dear children, Scout, Guide, claps, go! Here we all are having our delegates. So we all will give a special claps to our delegates. That is called the rocket claps go. The command is for me. All of you see to me how I am doing. Then the command will be given to you and you all will give the claps to our delegates. So see me. Command is for me. Rocket claps, go. Not for you, for me. Rocket claps, go. 1, 2, shh. 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 So, the command for our delegates, rocket claps, go. Thank you.
Big round of applause for ma'am.
So thank you very much, ma'am. Really wonderful. It is our first time experience again. Really wonderful. We are very happy to see all the faces, all the happy faces. So let's start the program. Before our presentation, I will invite our guest, Dr. Nora. Can we have two words from you for the children?
I'm a little bit overwhelmed, actually. I am totally amazed to see you all here. Thank you for coming. I'm very, very excited to have you be learning about the liver, something that I view as being very, very important. And one of the most important things that I heard is that you are going to be future leaders. And I think that that's the most important thing that I think you should take away, is that you're going to learn about the liver today, and then hopefully you will lead in terms of helping others to learn about the liver. So I'm looking forward to having an interaction with you today. Really, really excited to have you here. Thank you.
Thank you. Thank you, Dr. Nora, for these words. So I will invite our Professor Sandeep Nijavan sir, who is our President of Indian Society of Gastroenterology, to a few words for our children.
Good morning to you all. This is awesome. For the first time in my life, I am seeing so much of enthusiasm among the students to learn about liver. You are the future of our nation. You are the torch bearers. If you learn how to protect liver and you spread the knowledge to other students, I think you can change the future of the nation as well. So thank you for calling me. Thank you so much.
Thank you, Nijavan sir. So now the time for the presentation. So today's chief speaker, our chief speaker is a very academic, cerebral person, Dr. Ashish Kumar, and I will ask Dr. Ashish to have a small introduction, then his presentation for you, children.
Good morning, children. So, how are you? Are you happy to be here? So, why are you happy? You are happy because you are skipping your classes, or you are happy? Are you excited to learn about liver? That's why you are happy, or you are happy because you don't have to attend your classes? So how many of you are happy because you are skipping the classes? Okay. So there are few people. Okay. Okay, silence. Okay, tell me, which classes are you from? I cannot hear anything. So 7th, 8th, 9th and 10th. Okay. Okay, to tell me, how many of you would like to become engineers? How many of you would like to join army? How many would you like to become politicians, chief ministers, prime ministers? And how many of you would like to become doctors? Oh, a lot of them. So, all those who want to become doctors and engineers, do you like science? Okay. And what about mathematics? How many of you like mathematics? So, more of mathematics people are on this side than the science side. Okay. So, I'll begin my presentation. You must have read about liver and the digestive system in your classes, but here it will be in little bit more detail. So if you get bored or if you don't understand, you can raise your hand and ask questions. Okay, so let us make it more interactive. So my name is Ashish Kumar and I'm a doctor. I work in Delhi. And my field of specialization is gastroenterology. You know what is gastroenterology? So gastroenterology deals with the diseases of the digestive system. Once we take in food and then how the food is digested, and if there's some problem in that digestion of food, then all those diseases are treated by gastroenterologist. Okay, do you know what is a cardiologist? Who is a cardiologist? What does it treat? Okay, so you are all very bright children. So this question has been already asked. How many livers do we have? Okay, and tell me some internal organ which are 2 in number. Okay, very good, excellent. And which is the largest organ of the body? You are saying liver just because this session is on liver? Yeah. So who said skin? So that is correct. But among these options, of course, liver is the largest organ. So where is the liver located? Is it under the stomach? Is it on the right of stomach? Is it between the 2 kidneys? Okay. So you all probably know. So liver is the largest organ, largest solid organ, and it is also a gland. You know what is a gland? So glands are those organs which secrete some fluid. Okay. So like we have salivary gland. So that salivary gland secretes saliva. So there's many internal glands also. So liver also acts as a gland. It is the largest organ and it is reddish brown in color. And in scientific language like Greek and Latin, it is called as hepar. And from there the word hepaticus has come. So have you heard the word called hepatitis? Yes. It's a disease of the liver. So that disease means inflammation of the liver. So, and liver is located on the upper right side of the abdomen, and it weighs approximately 1.5 kgs, but it received almost 1/4 of the blood supply. The blood is supplied from the heart, and from the heart the blood supply goes to the liver, and also the liver receives blood supply from the intestines. So once we eat food, the food goes to the intestine, and from the intestine all the nutrients which are absorbed, those nutrients go into the liver. So liver in general is very soft and it is sponge-like. So this is the structure of the liver. So it has got basically 2 sides. One is called the left lobe, other is right lobe, and then there are certain ligaments. You know what are ligaments? Yes, ligaments and muscles. These are part of the connective tissues. Okay, so ligaments, there are certain ligaments which divides the liver into left side and right side. And have you heard of a organ called gallbladder? Yes. Okay, so you must have heard about many of your relatives whose gallbladder has been taken out, because gallbladder is an organ where certain stones can form, and then it causes problems, it causes pain, and then we have to remove the gallbladder. So gallbladder is very much related to the liver. That is, it is attached just below the liver. And if we go deeper into its structure in relation to other organs, so liver is very close to a structure called pancreas. Pancreas is an organ which produces enzymes. You know what are enzymes? Enzymes help in digestion of our food. So once we take in food, then that food goes into our intestine, and then pancreas produces those enzymes which help in digestion. Okay, so the food which is digested then gets absorbed, and the undigested food is discharged out in form of fecal matter, feces. Okay. And then gallbladder is an organ which stores the bile. Have you heard of a bile? Yes. So what do you know about? Someone can raise hand. What do you know about bile? Yeah. So tell me. Be loud. Very good. Excellent. Which class are you in? Excellent. So bile helps in digestion of fat. Okay. Then our food contains fat, our food contains protein and carbohydrates. and each of these things needs digestion by separate mechanisms. So gallbladder stores bile, and bile helps in digestion of the fat. And for protein digestion, we have pancreas. Okay. And carbohydrates are digested from enzymes which are produced in the intestine. So this is the internal structure of the liver, which is very complicated, but which you learn gradually in your higher classes, that it contains cells which are called as hepatocytes. Then it has got bile ducts. Bile ducts are those pipes by which the bile is carried. Okay, so this is the internal structure. Now tell me, what are the functions of the liver? Your options are: it helps to defend against germs in your body, it relieves mental tension, it acts as a filter to remove toxic substances, it produces bile, or you don't know. So what are the options? No, I can't hear. Someone who raised the hand, please get up and tell. Okay, so it removes. And what about bile? I was telling that it produces bile. So liver has got multiple functions. Okay, it also acts as filter to remove toxic substances. It produces bile. It also helps in defend against your certain germs or bacteria. Okay. So the liver is necessary for survival. A human can survive if the liver is removed. Then human can survive only for 24 hours. Okay. And liver performs, as Dr. Manoj had told, that it performs more than 500 functions in the body. So liver is so much vital organ. There are other organs which performs less functions. For example, the function of eyes is only to see. Function of ear is only to hear. But function of liver is so much that it does a lot of functions. So what are the function of liver? One, it helps in digestion. So it secretes bile. Bile is a greenish liquid which is secreted by liver, and then that bile goes into the intestine, and where it helps in digestion of fat and absorption of fat. Then it helps in metabolism. You know what is metabolism? So whatever we eat, we are eating chapati, we are eating rice, we are eating vegetables, we are eating fish, all that is broken down into 6 components. Okay, one is carbohydrate, then fat and protein, then water, minerals and vitamins. So all these 6 components are the part of our diet. So once these carbohydrates and fat and proteins, they are absorbed, then they need to be broken down, and then they are reconstituted into the substances which our body needs. For example, our body needs albumin. Albumin is a type of protein. When you eat egg, you see something which is yellow, which is in the center, and something which is outside is white. That white part is albumin. It is a type of protein. Okay. So similarly, albumin is also formed inside our own body, which is made from protein. So whatever protein we eat, that is first broken down into amino acids. That is the individual smaller component of protein, and then again those amino acids goes into the liver, and then liver starts manufacturing into the albumin and various other proteins which are required by the body. Certain proteins are required to actually clear the bacteria, or those are called antibodies, which are there to help to fight against diseases. Those are also type of proteins. Okay, so it helps in metabolism. Metabolism is breakdown as well as assimilation of the proteins and fats and carbohydrates, and then reconstituting. Then the other function of the liver is to store for the need in future. For example, it stores glucose. So even if we remain hungry for 24 hours, 48 hours, when we do fast, when we are doing fasting or when we don't get food, the liver has got lot of store of glucose, and that glucose can be utilized so we can live without even having food for certain days. It can also store fat. Fat are much more concentrated, gives much more energy than the glucose, because each fat molecule produces about 9 calories of energy. You know what are calories? Calories are the unit of energy. What you must have read in science, that unit of energy is joules or calories. Energy is the thing by which work is done. When you are moving, when you are running, you are doing some work, when you are studying, and for doing that work we need energy. And how do we measure energy? We measure energy by calories. So fat gives more calories than what we get from carbohydrates or glucose. Then vitamins and minerals are needed for various digestive and various other functions of the body, because they are in enzymes, these are there in various hormones. And where, you know what are hormones? Hormones are the substances which are produced by some glands, and those hormones then travel in the blood and then they act in a different part. Then liver has got also certain blood function, because it helps in breakdown of hemoglobin. Hemoglobin is a substance which carries oxygen in the blood. Then blood and also certain, where is blood produced in the body? Where is the blood manufactured? No. Yeah, someone from the back, you raised hand. Okay. Not able to tell. So the blood, yeah. No, heart actually pumps the blood. The blood is produced in a substance inside the bone. So inside the bone, there's a soft substance. You must have eaten mutton, so you know. Inside the bone is a substance that's called bone marrow. Usually blood cells, red blood cells, white blood cells, all those are blood components are manufactured inside the bone, in the bone marrow. But if in certain situation that is inadequate, then even liver can start manufacturing blood. Then also, once you must have noticed, suppose you get injured, if you are playing football and if you get a cut in the knee, then blood flows out for some time and then it stops. You know why it stops? Because there's clotting. So for clotting, there needs to be certain substances which help in clotting. Those are called clotting factors. Those clotting factors are also produced in the liver, and then they are mixed in the blood, and so they remain in the blood. And then, as I told you, that liver produces albumin, which is a very good form of protein and which is needed by our body for various functions. Then liver helps in protection against infection. So it is an immune organ. You must have heard people saying that how good is your immunity? If your immunity is low, if your immunity is poor, then you will get diseases very often. You will catch cold very often. You will get infections very often. Recently, when there was COVID time, people were saying that people who had low immunity were catching COVID much more often and they had severe disease. So those immune factors or immunity is also produced by the liver. There are other organs also which helps in immunity. So liver activates body's immunity. Then also liver removes the waste products, certain waste products. So those waste products, for example, certain toxin, if we eat certain poisonous material, so it's not necessary that we'll die, because liver will help us to remove that poison. Okay, so all the toxins also can be removed. But if we consume excess poison, then obviously we will die. But if the poison is less in amount, then liver helps to detoxify or remove that poison. So that poison breaks down into harmless substances and then it is excreted through the intestine. And also people who drink alcohol, wine, whiskey, and any form of alcohol, beer. So that alcohol is actually not good for health. People who drink alcohol, then they have diseases. So liver actually tries to remove that alcohol from the body. So if someone is drinking alcohol in a limited quantity, then liver will break down that alcohol and it will remove it from the body so that its harmful effects are not there. But if certain people consume it regularly for a long period of time in excess amount, then liver will become overwhelmed and it will not able to function. Okay. So now I'll tell you briefly about diseases of the liver. So this is the healthy liver. So mainly the liver will have three types of diseases. One is the inflammation of the liver, second is scarring, and third is the cancer. So you all know what is cancer. Cancer means tumor. Cancer is a deadly disease. Most of the people who get cancer, if it is not diagnosed early, if it is not caught, treated early, then the cancer can spread throughout the body and then it's bad for the person and he dies. So liver can get cancer. The other two diseases are inflammation of the liver and the scarring. So what is inflammation? Can anyone tell what is inflammation? Yeah, someone from the back. Yeah. Yes, exactly. So inflammation means once there's some injury. For example, when you fall down and you injure your knee, the knee will become swollen. It will become red. It will also feel a bit warm. So all these things are part of inflammation. So whenever there is some injury to any organ of the body, be it your knee, be it your elbow, or be somewhere inside your body, the inflammation is body's response to make that thing right. So why do we have swelling and why do we have redness? Because that organ, that area wants to heal itself. Okay, so for healing itself, it calls more blood around that area. So that's because of excessive of blood in that area, it becomes red. So you must have seen even if there's a mosquito bite, the area becomes swollen and it becomes red because the body tries to heal the toxins which are put there inside by the mosquitoes. So the body will try to heal. So that healing mechanism, trying to heal, is called as inflammation. So once the liver gets infected due to something, the liver will try to heal itself by inflammation, and it will become red, it will become swollen, it will enlarge. The other thing is called scarring. So you must have seen that if you fall down and if you have got a really bad cut, and then that scar will be there for a lifetime. Then even you can remember that in class 3rd, I fell down in my knee and got injured, and then that scar is still present. So that is called scarring. Scarring is a permanent damage to an area which is due to some injury. So liver also can get certain diseases and that leads to scarring, and that scarring can actually cause certain problems. So there are 3 types of liver disease: inflammation of the liver, scarring of the liver. The scarring of the liver is called cirrhosis, inflammation of the liver is called hepatitis, and then cancer. So this hepatitis is again of 2 types: acute hepatitis, which will be of short duration, last for few months, and then chronic hepatitis, then it can last for years. That means the inflammation is ongoing, it is continuing, it is not able to resolve. The most important symptom of acute hepatitis is jaundice. Have you seen people who are, you know what is jaundice? In jaundice, you must have seen your friends, or you might have also developed jaundice some time, that your eyes become yellow, and then your urine is also of yellow, excessive yellow color. So this is a disease of jaundice which can occur due to various reasons. And then this jaundice is due to a virus which is affecting the liver and which is causing acute hepatitis. in chronic hepatitis, although the inflammation is going inside the liver, but usually there are no symptoms. So the doctors are able to tell about the chronic hepatitis only when we do certain tests. When we do certain blood tests and we find there's certain substances in the blood are abnormal, then we say that the person is suffering from chronic hepatitis. But if chronic hepatitis goes on for a long time, for years together, because there's lots of inflammation in the liver, then it can lead to that same thing, that is scarring. And that scarring is called, in scientific language, it's called cirrhosis of the liver. Okay? So scarring, whenever there is a scar tissue found anywhere in the body, it is irreversible. That you will know the scar will be present, and it will be present throughout the life, and it's very unlikely that the scar will vanish completely. So liver once becomes scar, its shape also changes because of the scar tissue, and then because of the scar tissue, it was doing 500 functions, but now it is not able to do all those functions properly, and even some of the functions it is not able to do at all. And once the scarring is there, then that disease actually gradually becomes, once there's scar, then the scar attracts more scar, and then the disease progresses, and these patients can die within 5 to 7 years. Sometimes these with treatment, then they can survive also. But with scarring of the liver, the diseases, the symptoms which occur is sometimes they may have vomiting of blood. Sometimes they may develop jaundice. Some of these patients may have fluid in abdomen, and sometimes these patients may also develop coma. Okay, you know what is coma? These patients may become unconscious. That is coma. And so once the liver becomes very much scarred, very much damaged, then there's no treatment except we'll have to change the liver. Changing the liver, that means we have to remove the bad liver from that person, and then someone else either donates a part of the liver, and sometimes even certain people who have died in the accident or somewhere, then we can take their liver, and then that liver can be used for that patient whose liver has scarred. Yeah.
So, sorry for the interruption. I will welcome Rajendra Swar to the stage, please, sir. And Dr. Susan Sethi today. Eminent hepatologists. So, we have two eminent hepatologists here. We are there, no doubt, but we have Dr. Rajendra Reddy and Dr. Nora. And now, you will be pleased to know that we have now our President of this Liver Society of India, Professor Shivram Prasad Singh. Sir, welcome you here to the liver workshop. Sorry for the interruption, Dr. Assis. Please continue.
Okay. So, who is the President of India? Where is she from? Yeah. So, 3 cheers for President of India. So similar to our Indian president, so we have our own liver society. So liver society consists of doctors who treat liver diseases. So the current president of the liver society is Dr. S.P. Singh, who is here, who has just come. So again, clap for him. So he is also from Orissa. You must have seen him in TV and newspaper telling about liver. Okay. So I was telling about the cirrhosis I told. Then the third disease of the liver is called liver cancer. Cancer is a deadly disease. It's a tumor which is formed in any part of the body. So you can have cancer of the intestine, you can have cancer of the lungs. So do you know how do people get lung cancer? Lung cancer, yeah, tell. Yes, smoking is the most important cause of lung cancer. Okay, and similarly, how do people get liver cancer? Can anyone tell? Yes, yes. Yes, so drinking is one important cause and smoking also contributes. So smoking is very bad, and first you promise that you will never do smoking in your life. Okay? And similarly, never take alcohol. Okay? So liver cancer is a disease which is produced, which happens to people who are drinking lot of alcohol, and also it happens to people who have caught certain viruses like hepatitis viruses. So hepatitis B is a bad virus, hepatitis C is a bad virus. If that virus comes inside the body, then it remains in the body for a long time, and then it causes scarring of the liver, and then these patients may develop liver cancer. So if the cancer is small, anywhere in the body, be it in lung cancer, be it in bone, be it in anywhere in the liver, if the cancer is small, the best treatment is to remove that cancer. Okay, so if the cancer is small, the best treatment is surgical removal of that cancer. But if the cancer is big, so this is the liver, and such a huge cancer is there. So it's very difficult for huge cancer to be removed. So that time, what we have to do, we have to remove the entire liver, and then we have to put a new liver from someone else who has died, but whose liver is healthy. So that process is called liver transplantation. Okay. Have you heard of people who have donated their eyes? Okay, so that's called as cornea donation. So people actually write, they pledge that if I die in some accident or by any cause, if my eyes are healthy, then those eyes can be donated to person who is blind, who has corneal diseases, and then that person can see again. So it is such a good thing that if we pledge to donate our eyes. Okay. Similarly, people can donate their kidneys. Okay. So we have 2 kidneys, and one can be donated to our friends or relatives whose kidneys are not working. So once kidneys are not working, kidneys are failed. So what happens? What do the kidneys do? What do they make? What do kidneys make? Urine. Yes. So if kidneys are not functioning, then that person will not be able to produce urine, and urine is by doing urine, people remove the toxic substances. So because those persons are not able to excrete urine, so lots of toxic substances are there in the body, and that cause harm. So the doctors need to put a new kidney into that person. That's called kidney transplantation. Similarly, there is liver transplantation. And there are many other types of transplantation. There's a bone marrow transplantation. If the person's blood cells are damaged, then even bone marrow can be changed. Okay. And there's lots of, even heart can be transplanted, liver and lungs can be transplanted. So lots of advancements are going on in the scientific field, and so we are seeing lot of advancement. So liver transplantation is a treatment for the disease which are not cured by normal medicines, and it has become so scarred, or if there is a lot of cancer which cannot be treated by surgical removal, then liver has to be changed, and it's called transplantation. So what are the common causes of liver disease? Is it shaking hands? Is it eating unhygienic food? Is it smoking? Is it drinking alcohol? So someone who has raised hand, you answer. Yeah. Alcohol, smoking. What about eating unhygienic food? Yes. So if if people eat unhygienic food which is unclean, then that unhygienic food can contain certain germs, certain viruses. There are many types of viruses. I'll tell about them. So those viruses can come inside our body by unhygienic food. So eating unhygienic food, drinking alcohol, smoking, these can cause damage to the liver. So, as I told you, there are two types of hepatitis: acute hepatitis, which is caused by viruses, hepatitis A virus, hepatitis B. There are 5 types of viruses: A, B, C, D, E. It's very easy to remember. If someone asks you what are hepatitis viruses, you just tell them A, B, C, D, E. Okay. So out of the acute hepatitis, which lasts for a short duration, that means 1 to 2 months, are caused by hepatitis A virus, hepatitis B virus, or hepatitis E virus. And then also acute hepatitis, that means inflammation of the liver, can also caused by certain medicines which are harmful. For example, certain painkillers can also cause hepatitis. Certain antibiotics can cause hepatitis. Even certain Ayurvedic medicines can also cause hepatitis. So certain drugs which do not suit us can cause hepatitis. The chronic hepatitis is caused by hepatitis B virus, hepatitis C virus, hepatitis D virus. So B virus can cause both acute hepatitis as well as chronic hepatitis. And chronic hepatitis is also caused by alcohol. So those people who continue to drinking alcohol for a long time and lots of alcohol, then they get chronic hepatitis. That is called alcoholic hepatitis. Okay, and then obesity. So you are all young and slim and trim, but as you grow old, there's a tendency to eat lots of junk food, and that junk food causes what? You become fat. That's called obesity, and obesity is bad for your liver as well. Okay, so I'll not go into very much detail, but some of these hepatitis viruses are spread by food and water. That means dirty food and dirty water. And then there are other hepatitis viruses which are spread through infected needles and blood transfusion. So you must eat healthy food and clean food to protect your liver. And this tattooing can cause also certain types of viruses to spread. So try to avoid tattooing. Okay. And so I'll skip all this. Can you recognize who is she? Okay. And have you seen a film called Devdas? And who is this actor? Yeah, all this, you know. So if those of you who have seen this movie, Devdas, in Devdas, the hero, Shah Rukh Khan, his name was Devdas, he used to drink lot of alcohol. And that alcohol actually caused his liver damage. So if you remember the end part of the film, he dies because of the liver disease. And he has blood vomiting and all that. So alcohol is so bad. So it causes alcoholic steatohepatitis. So you can remember ASH. ASH means Aishwarya Rai. And alcoholic steatohepatitis is a disease which is caused by alcohol. Okay. So what are the effects of liver? Alcohol, it causes liver failure. Okay. And also if you eat lot of junk food, lots of burger, lots of pizzas, lots of Maggi, then you will tend to become fat, and you'll become as fat as this lady. And then when you have become lot fat, then you tend to get lots of diseases. You get liver diseases, you get heart diseases, you get so many other diseases. Okay. So to prevent liver diseases, you have to eat clean food, you have to eat healthy food, you have to do lots of exercise. So all of you do exercises? So you have PT time where you do exercise. You also need to play lots of sports, football, badminton, hockey. Okay. And you also need to, yes, you have some question? Yes. Cause of fatty liver? Yes. So cause of so it's very easy to remember. Once we become fat, then our liver becomes fat, and so that is the cause of fatty liver? So one of the most important cause of fatty liver is we becoming obese. And how do we become obese? If we eat lot of junk food. Junk food means the food which contains lot of carbohydrates. These are called as empty calories. That means they just contain lots of carbohydrates. They don't have good nutrition, like they don't have lots of vitamins, they don't have fiber. So that is called junk food. If we eat lot of junk food, then we become fat, and then our liver becomes fat, even our heart becomes fat. So all this is due to that. Okay. If you have any other question, you can raise your hand, then I can answer. Yeah, you have some question? Yeah, you take this mic and then again introduce yourself so that everyone knows your name. Yeah, again say.
Good morning, sir. I'm Sanvi Das from DAV Public School, Unit 8, Bhubaneswar.
Yes.
So my question is, cirrhosis adversely affects our health, our liver. So can you please explain it, how it adversely affects our health?
Adverse effect due to cirrhosis. Okay, so I told you the cirrhosis means scarring of the liver. Liver becomes scarred. So, for example, again, I'll give you same example. If you get injury in your knee and there's lot of scarring, then you're not able to run fast. So, similarly, if the liver is scarred, then it will not be able to perform all the nice functions which is doing. Liver does 500 functions, so it will not be able to do. So, it will not be able to produce albumin. It will not be able to produce all those clotting factors. So liver will not be able to do all the metabolism of the substance. It will not be able to digest fat. It will not be able to digest. So the person will become malnourished because he's not getting enough nutrition. And then gradually because the liver will start failing. It's called liver failure. And then the treatment will be to change his liver. Okay? We'll
have an interaction session. Okay,
let me just finish this.
You will ask question. Enough question. We'll interact.
And then all the experts can answer. Okay. So let me just finish. The only last few slides are there. So we must eat clean food. We must eat healthy food. That means healthy food means balanced meal. Not excessive of carbohydrate, not excessive of fat. Okay, it should be balanced. It should contain carbohydrate in the right amount, protein in the right amount, fat in the right amount, and vitamins, minerals, and water, adequate amount of water. So that is called healthy, balanced diet. And this is for doctors that they should, whenever they give injections, they should use sterilized needles and syringes. And then everyone needs to have vaccination, and then you should never be addicted to alcohol or smoking or any other bad things. Okay, so you should always remember that you'll remain slim and trim, because you'll always look beautiful when you are slim, and also your liver will also always remain beautiful and it will remain healthy. So so obesity damages the liver. Keep your weight in check. Do not be overweight. Okay, do exercise. Should not eat too much of fried food, too much of carbohydrates. Okay, and you should always eat lots of fresh fruits and vegetables. They are very good for liver. They give lots of vitamins, and they prevent us from becoming fat. Okay. So is there a vaccine for hepatitis B? Yes. So that vaccine of hepatitis B is now given to all the newborn children. It is given along with your other vaccines, like vaccines for polio, diphtheria. You learn about this as you come to your class 11th and 12th. And then treatment of, if someone gets jaundice, the treatment is to take him to the doctor. The doctor will decide whether he will need admission, and then we should give good nutrition. What people do is that when people become jaundice, people advise that you should not eat. You should just take water and juice. That's not the correct advice. The people who are jaundice should get adequate nutrition. Okay, and the treatment of cirrhosis is liver transplantation. Is liver transplantation done in India? Yeah, so now liver transplantation is done in India, and people can donate liver to their near and dear ones. So the whole liver is not taken out; only a part of liver is taken out. And liver is such a nice organ if it is healthy, and even if we cut half of it, it grows back into full. For example, if we cut your skin, the skin grows back. Similarly, liver regenerates and it grows back. So it will grow back within 4 weeks if a part of the liver is taken out and is donated to some other people. Okay. So this is, for example, in this person, half of liver was donated and then that half was put in the person whose liver was diseased due to cirrhosis, and then that person now is able to function well. So health is the thing that makes you feel that now is the best time of your. If you're healthy, you'll always feel good. You'll perform good in your studies. You'll perform good in your sports, and you'll become the true leaders, as we all told, your future leaders. Some of you want to become doctors, engineers, politicians, film actors, sports persons. So if you keep your liver healthy, if you remain healthy, then you will able to achieve all your ambitions. Okay, thank you.
Thank you, Dr. Ashish, for nice presentation. Bhal lagila ki? Bhal lagila? Bol lagila ni? Biology class बढ़िया लगला नहीं तो नहीं. So मो colleague जने कहले बे, he told me people, these children have skipped their classes and we are teaching here biology or something. मो कहली okay, so तुम्हार enjoyment पाई what you will do? You know selfie? We'll take selfie. I promise you, we will take selfie with him. The who's and who's of hepatology, liver. Huh? So you know all these dignitaries. You now listen to Dr. Ashish, and now Dr. SP Singh, our liver society ro se hele president. Our Dr. Nora se hele hepatitis upre bahut research करछंती. Lot of papers on hepatitis. आतंक पाखे बसचंदी डॉक्टर राज. वी आर प्राउड अगेन आम से इंडियन सेठी जाई कि आमे जो लिवर बही पढुनु व्हाट एवर लिवर बुक वी आर रीडिंग, ही हैज रिटन दैट लिवर बुक. वी आर रीडिंग द बुक व्हाट ही हैज रिटन. एंड तांको साइड रे बसचंती आउ जने सीनियर गैस्ट्रोएंटरोलॉजी हेपेटोलॉजिस्ट आम सहर भुवनेश्वर सहर डॉक्टर सुशांत सेठी. सो आमे नेक्स्ट बिना आउट टिके इंटरेक्ट करबा. जो क्वेश्चन अछि तुमरो आई विल आंसर इंटरेक्ट विथ दिस एक्सपर्ट ग्रुप सहित इंटरेक्ट करबा. आफ्टर दैट आई प्रॉमिस यू विल टेक सेल्फी विथ दोज हूज एंड हु. ठीक है? ओके.
Okay, do you know who is the president of United States of America? USA? Okay. So, like I told you, the president of Indian Liver Society is Dr. SP Singh. Similarly, the president of the Liver Society of America is Dr. Nora.
Great. So, केते बुझिले आमे. So, liver बहुत पाठ पढ़ले ना, बहुत टाइप ऑफ डिजीज अच्छी, बहुत टाइप ऑफ ये अच्छी. सो मु बेसिकली जदि बिफोर इंटरेक्शन जदि कहि देबी कि लिवर आमे वी कैन सम डिजीज प्रिवेंटेबल डिजीज और सम डिजीज नॉट प्रिवेंटेबल. ठीक अच्छे. आउ हेल्थ गोटे कहले डॉक्टर आशीष, ही टोल्ड तुमे बड़ पिला हेलोनी, हु नोज द डेफिनेशन हेल्थ? वन पर्सन हेल्थ र डेफिनेशन जानिଛ पढ़िଛ हेल्थ र डेफिनेशन? रोग हेले खाली अनहेल्दी की. सो हेल्थ इज डिफाइंड एज, ओ ग्रेट, वेरी गुड. योर नेम?
Omshi Badapanda from St. Joseph's High School. I think health is being physically and mentally well.
Very good. So health is physically, mentally, socially, physically, mentally, socially healthy हेले हमें health कहूँ. आउ गोटे दीटा मु जोड़ी दिए सेथरे physically, mentally, socially, emotionally, spiritually and economically भी जोड़ी दिए बड़े बड़े. This is not in book मु जोड़े. So गोटे preventable आउ गोटे not preventable, and you know that preventable जेते liver disease अच्छी, out of that liver disease 100टा जदि liver रोग नेबा liver रोगी 90 to 95% 90 to 95% of the liver रोग जहार कारण हमें जानूछु सेटा preventable. तुम्हें जानी छ ना, you know a stitch and time saves 9. ता माने कौन? What is the meaning? आमे जदि ठीक समय रे will prevent it, we can prevent lot of things. That we can spend 1 rupee, we can, by spending 1 rupee we can save lot of rupees. ठीक है? So जो preventable liver disease मु कहली सेथरु गोटे हेले सर कहले, डॉक्टर आशीष सर कहले, one is मोटापा. Now that is most common liver disease है fatty liver disease. Fatty liver रे चर्बी जमा हो जाउची. जानि छ इंडिया रे केतेटा fatty liver लोग अछंती रोगी? तार अछि रिपोर्ट धर की, अरे बाप रे, वेरी गुड. आमे देखिबा तांको रिपोर्ट भी देखिबा. सो खेलु न कि बाबा तुमे खेलु छ? वेरी गुड. सो 4 जन करे गोटे, 4 जन करे गोटे. इंडिया रे 3 जन करे गोटे हे गेली. काहे कि ना वी आर ईटिंग मोर. कोन खाउछु? जंक फूड. तुमे खाउछो कि? नो, समटाइम टेक लेस. सो आमे जदी मोटापा रोग, हेपेटाइटिस रोग सेटा भी प्रिवेंट करि परिबा. हां, आउ हमर हेपेटाइटिस रोग, फैटी लिवर रोग, अल्कोहल रोग सब को प्रिवेंट करि परिबा. ठीक अछि. एबे मु आ बेसी समय वेस्ट करबिनी. जहा क्वेश्चन पचारिबो मु एक्सपर्ट मान को सहित तुमरो इंटरेक्ट करबी. सो किए किछि क्वेश्चन पचारिबो? चिड़ा हो.
Sir, I am Guru Prasad Upadhyay from St. Joseph High School. Sir, my question is, as usually heard, that painkillers cause damage to liver. Is it true or not?
Okay. So, kaha ko pachariba? Expert rehte.
Sir, Ashish.
Huh?
Sir, बोलते सुन लो.
So, Dr. Noora, the child is asking, can painkiller cause hepatitis or liver damage? Painkiller.
So really any medication, we should be thoughtful about what it might do to the liver. Painkillers in particular that it contain acetaminophen. What's the word? Is the same here? Acetaminophen? Okay, acetaminophen. Those are the ones in which there's the real risk in terms of if you take too much of those painkillers, it can cause an acute form of liver injury that can be very, very severe. So anytime you take any medication, you should do so only with good guidance from your physician, your doctor, and in particular, be careful about taking pain medications of any type, but in particular those that include acetaminophen.
So, बुझी पारला कौन पेनकिलर?
मानस
सर,
से जो मेडिसिन ना कहले तमे से मेडिसिन जानिछ, क्रोसिन ना रे जानिछ, क्रोसिन पथा पथा लिखाओ से क्रोसिन. जदि बेसी क्रोसिन खाई दबो एते खराब हो जो लिवर जे राम नाम सत्य है. बुझलो हला? तापर लिवर ट्रांसप्लांट करिया पड़िबो. मो कथा बुझछु? हां. सो आउरी सब मेडिसिन जे कोन से मेडिसिन ते लिवर असुविधा हेई पारे. डॉक्टर को पचारी खाइबो केते खाइबार अछि कोन?
कौन सी मेडिसिन डाक्टर माने केते बेले दियंती कहलो? जेते बेले आमे बेसी लाभ पाऊँ से मेडिसिन नहीं कि क्षति करवाठू सबु मेडिसिन रो किछि ना किछि साइड इफेक्ट अछि जेते बेले लाभ पाऊँ बेसी क्षति ठू ताहले जी निया जाए तो कौनसी मेडिसिन घरे बापा माँ तुमको दौरान कि तुम्हें निजे नौछ केबे भी निजे निजे बिना डाक्तर परामर्श रे नेबानी सो मैडम कहले सार कहले कौन पेन किलर भी खाइले असुविधा हुए तो कौनसी मेडिसिन आमे बिना परामर्श रे नेबा नहीं।
सर मो ना अंचितार पात्र मु सेंट जोसेफ हाई स्कूल सर मोर गोटे डाउट थिला कि जो लिवरटा आपण जो कहले सर बढ़ुची से सेलटार ना कहि पारे ठीक से जो लिवर जो बढ़ुची से सेल रो नाटा कि कहि पारे और से रीजन टा कोन पे बढ़े से फिर से
most probably he is asking Dr. Ashish liver cell tumor most probably he is asking about tumor so काहे की बढ़े पचारुच reason okay liver tumor reasons of liver tumor
okay liver cancer I told you liver tumor is any form of abnormal growth in the body okay it's a form of cancer okay so liver cancer can occur due to excessive alcohol if someone is drinking lots of alcohol then the person can get liver cancer okay the liver cancer can also develop in patients who are having that virus hepatitis virus for a long time for many years if the hepatitis virus is there and it has damaged the liver then it can cause liver cancer. And also people who have lot of fatty liver disease and then their liver gets damaged and cirrhosis has occurred, then also liver cancer can develop. Okay?
So, tumor, sir कहले ना tumor गोटे कैंसर गोटे बहुत dreaded disease कहले ना हमें ट्यूमर को प्रिवेंट कर पारिबा कि यस दीटा कैंसर अछि जाटा को हमें प्रिवेंट कर पारिबा एटा तुम एमसीक्यू रो भी आसी पारे दीटा कैंसर हमें अटकै पारिबा कोन को कैंसर गोटे एटा लिवर कैंसर हेपाटाइटिस बी जनित लिवर कैंसर आमे ताकू प्रिवेंट कर पारिबा जदी गोटे स्टोरी कहबी ताहले ताइवान बोल की गोटे कंट्री अछि जानि छ कि दैट ताइवान कंट्री रे जेते बेले देखा गला लिवर ट्यूमर बहुत होछि लिवर कैंसर बहुत होछि आ जेते बेले बाहरिला 1980 मसिया रे सेते बेले तुमे मैं भी तुम बापा माने जन्म होतबे सेते बेले ना तुम माने जन्म होई नथिला सेतकी बेले जेते बेले से देखिले कि हेपाटाइटिस बी पई होछि हेपाटाइटिस बी टीका वैक्सीन जोटा सर कहिले एबे हेपाटाइटिस बी वैक्सीन देबा आरंभ कले तो लिवर कैंसर टा ड्रास्टिकली बहुत कमी गला सो लिवर कैंसर हेपाटाइटिस बी जनित लिवर कैंसर को आमे अटकई परिबा ता पई कोन टीका नेबा तुमने समस्त नै छ ना समस्त जन्म 2007 पर होइछि माने समस्त नै छ तापरे तुमे तुम पेरेंट्स मान को कहिबो से माने नै छंती कि नै आ जाय कि चेक करबा पई कहिबो हेपाटाइटिस बी आमे लिवर वर्कशॉप रो सुनलु प्लीज चेक योर हेपाटाइटिस बी स्टेटस एंड टेक वैक्सीनेशन जदि नेगेटिव अछि ठीक अछि आ गोटे कैंसर प्रिवेंट करि हेबो गोटे हेपाटाइटिस बी रिलेटेड लिवर कैंसर आ गोटे कोन लंग कैंसर नाही आ गोटे अछि वायरस जनित एचपीवी कहंती सर्वाइकल कैंसर जोटा फीमेल मानकर हुए सेटा को प्रिवेंट करि हेबो आमे सेटा अटकई परिबा ओके somebody is asking question
Manas?
Sir.
Sir. I just want to ask the audience a question. So they've heard a lot about fatty liver disease, right? You all heard about fatty liver disease and how to prevent it. You've heard about it. So what's the next thing you think you should do? Do you follow my question?
Question बुझी पारलो? You want to answer? So question बुझी पारलो कि तुमे चर्बी लिवर रे चर्बी थिबा रोग सुनलो नै फैटी लिवर डिजीज सो फैटी लिवर डिजीज जहाँ सुनलो आमे नेक्स्ट कोन करबा व्हाट नेक्स्ट वी शुड डू एनीबॉडी
Yes, there's someone here.
We should eat healthy food rather than eating oily foods like French fries, burger. We should cut down all of this.
Yeah. So that's all good, but you really need to go home and educate your parents and your uncles and aunts. You do a big service if you did that. It's not only you, it's around the people around you. You should really educate your parents and uncles and aunts how to eat healthy and take care of themselves. How many have parents who are diabetics? See, not uncommon. So you got to try and educate them. All right, you would accomplish a lot more than just taking care of yourselves.
Okay, so this is Anshita Shukla from Devi Kalinganagar, and first of all, I would like to thank you for your great presence. It was really knowledgeable and it was really fun learning so much about liver. And I would like to ask this question to Mr. Singh, that what are the causes of a fatty liver, and what differences can we feel in our body if we have a fatty liver?
Thank you, Ansita.
There are two types of fatty liver, mainly. There are so many types, but there are two main types. Shuniparcha? Subhujita? How? So, ଦି ପ୍ରକାର ହୁଏ. ଗୋଟେ ହେଲା ଯଦି ତମେ ଯଦି ମୋଟା ହେଇଯିବ, ଓଜନ ବେଶୀ ହବ, ହେଲା? ଆଉ ଦ୍ୱିତୀୟ ହେଲା ମଦ ଯୋଗୁ, ମଦ ପିଇଲେ, ହେଲା? ମଦ ପିଇଲେ ବି ଫ୍ୟାଟି ଲିଭର ହୁଏ, ଆଉ ମଦ ନ ପିଇକି ଯୋଉଟା ହୁଏ ସେଇଟା ଅଧିକା ଓଜନ ହେଇଗଲେ, ବେଶୀ ଖାଇଲେ ଖାଇବା ଆଉ ତମର ଯୋଉ ଆକ୍ଟିଭିଟି, ଫିଜିକାଲ ଆକ୍ଟିଭିଟି, ତା ଭିତରେ ଯଦି ଠିକ ବ୍ୟାଲେନ୍ସ ନ ରହିଲା, ହେଲା? ତମେ ଆଇଦର ନର୍ମାଲ ଖାଉଛ କିନ୍ତୁ କିଛି ଆକ୍ଟିଭିଟି କରୁନ, ଖାଲି ବସି ପଟେଟୋ ଖାଉଛ, ଖାଲି ବସି ଟିଭିରେ ବସି ଦେଖୁଛ, ଟିଭି ଶୋ, ହେଲା? नो ସ୍ପୋର୍ଟସ, नो गेम, ନଥିଙ୍ଗ। ସେଇଟା ହେଲେ ବି ତମର ହବ। ତ ଦୁଇଟା ହେବା ଦରକାର, ଖାଇବା ଠିକ ହେବା କଥା ଆଉ ଏକ୍ସରସାଇଜ ରେଗୁଲାରଲି ହେବା କଥା। ତ ସେଇଟା ଯଦି ଠିକ ହଉନଥିବ ତାହେଲେ ତମର ଫ୍ୟାଟି ଲିଭର ହେଇପାରିବ, ଏକ। ଆଉ ଦ୍ୱିତୀୟ ହେଲା ଯଦି ମଦ ପିଇବ ତମେ ତ ତମର ଫ୍ୟାଟି ଲିଭର ହବ। ତ ଇଏ ଦୁଇଟା ହେଲା ମୁଖ୍ୟ କାରଣ ଯୋଉଟା ତମର ଜାଣିବା ଦରକାର। ଆଉ ତ ବହୁତ କାରଣ ଅଛି, ସେଗୁଡ଼ା ତମ ଜାଣିବା ଏତେ ଦରକାର ନାହିଁ।
କହିବ।
This is Sambhav Das from St. Joseph High School Group. I want to ask a question. Do drugs like antibiotics and ibuprofen as well as green tea extract harmful for our liver? To Sushant sir.
So what he asked,
drugs, ibuprofen, antibiotic is harmful for liver or
yes,
not?
Yes. Very good question. First, congratulations to you for asking this question. Okay, so you want to clap? You want to clap for this question? Yes, please. All of you are clapping for us, so we want to clap on that same tone for you, because you are the future of our nation, and you have attended a beautiful meeting, and it looks very nice. So we want to, and all of us, we want to clap for you before I will go, answer this question, and our scout guides will correct us.
So anybody want to ask question? Come here.
How was it? How is the Josh? How is the Josh? Yes. So answering that question, drugs, herbal and antibiotics, others. All drugs, as Manas said, are harmful if they are not taken in right dose, right combination, right time and right way, that can cause harm. So drugs should be taken for the good. It should not do any bad. So any drug you should not take without asking or doctor supervision. Second, regarding leaf extract and other things. So what research we have done, many of the drugs what we are using, we have made the research The scientists have made the research. They know what bad things the drugs are having. So people, those who are making, they know it. And we are advocating the people, you take this, you don't take. But unfortunately, this lip and other products, we don't know what it causes. So, तारो बैड इफेक्ट विषय हमको जाना नहीं को मान करो जो आमे देसी चेरोमूली आयुर्वेदिक अन्य कहूँ तार बैड इफेक्ट विषय हमको जाना नहीं जहाँ विषय हमको जाना नहीं से बहुत क्षति करि पारे आमे देखिछु लिवर बेले से फेलुअर करि पारे लिवर पूरा खराब कर दे पारे आउ आइबुप्रोफेन जे कोनसी पेन किलर कथा कहउतले पेन किलर माने बहुत खराब खाली लिवर नुहे से लिवर किडनी हार्ट ब्रेन सबुथिरे प्रॉब्लम करि पारे तेणु एनी ड्रग जो राइट डोज राइट कॉम्बिनेशन राइट टाइम राइट वे राइट सुपरविजन नेले सेटा भलो जदि ताठु किछि व्यतिक्रम घटिला ताले सेटा खराब
Please ask.
Good morning, sir.
Name?
So I have a question for you. How many in the room here drink sodas?
केते जन सॉफ्ट ड्रिंक्स पियो थम्स अप कोका कोला केते जन पियो समस्ते
Okay. So you've heard a lot about fatty liver, and those sodas are the #1 culprit for producing fatty liver. So the most important thing that you can do is to give up the sodas and shift to water.
So what ma'am told, you understand? एटा फॉर्चुनेटली ए सेम स्टेटमेंट आम सिंह सर डॉक्टर सिंह सर से गोटे स्टडी करथिले एठी अबाउट दिस फैटी लिवर ना आ सेथि हमें देखिथिलु नो डाउट सेथि मु भी अछि से देखिथिलु कि ए सोडा सॉफ्ट ड्रिंक्स कोल्ड ड्रिंक्स ना अल्कोहल भलिया एटा भी से तुम लिवर को डैमेज करिवो सो आज तू प्रॉमिस करो कि सॉफ्ट ड्रिंक्स आ पीबनी बिफोर हमें आउ किछिटा क्वेश्चन नेबा मु तुमको कहि दिया आपन को मैडम मान को भी तमने सर माने जे अछंती समस्त को तो इंट्रोड्यूस करली मु मोर नाटा कहि दिया आ मु गुटे तुमठु आई नीड ए प्रॉमिस फ्रॉम यू फ्रॉम टुडे सो मु हेली डॉक्टर मानस कुमार पानीग्राही एडिशनल प्रोफेसर अछि एम्स भुवनेश्वर रे मु गुटे प्रॉमिस चाउठी तुमठु तुम मैम कोन थ्रू आज जो सेशन टा हमें कले की करूछे आई नीड सम स्टोरीज सम पोएम जदि लिखि परिबो लिवर रे लिवर उपरे व्हाट यू लर्न फ्रॉम टुडेज वर्कशॉप सम स्टोरीज और पोएम आई विल गिव माय एड्रेस और ईमेल आईडी और समथिंग टू योर टीचर्स एंड यू सेंड थ्रू देम टू मी हमें देखिबा केते बढ़िया स्टोरी लिखि परछो आई विल गिव अ प्राइज टू यू जार स्टोरी और पोएम टा बेटर बेस्ट हला ठीक अछि
मानस तंको एठी ईमेल कहि दियो ना fattyliver@gmail.com लिखे दियोनी मने रहबो
fattyliver@gmail.com सेतरे तुमे मेल टा पठा देबो तुम स्टोरीज और पोएम अबाउट लिवर हाउ टू कीप लिवर हेल्दी व्हाट यू हैव लर्नड हियर यू हैव टू मेल दैट योर पोएम और स्टोरी or whatever you are experiencing to that mail ID, okay? And we'll give a prize.
Good morning, sir. I am Ayush Das from Sai International School, Patia. I have a question for Ashish, sir. Sir, after a liver transplant, how to control the side effects or keep it to the minimal?
Okay, so after liver transplantation, see what happens when once a new liver from someone else has been put to the patient, then that liver belongs to some other person. So body tries to reject that organ. So we have to give certain medicines to so that that rejection doesn't occur. So that person who has received that liver transplantation has to regularly take that medicine. That is number one thing. And second thing, he should not damage his new liver again. So he should try to avoid getting fat again. He should try to avoid alcohol. He should try to prevent all those diseases like viruses So that way the new liver will remain healthy and the person will remain healthy. Okay?
Sir, you.
Good morning, everyone. This is Ayusha Nandita from DAV Public School, Kalinganagar. My question is, what is the success rate of liver transplant in India, and what is the change in the lifestyle of the people, basically the patient and the donors?
Okay, the success rate is above 95%. Okay, so almost 95, 90 to 95% persons who undergo liver transplantation are successful. So it's a hugely successful, and it is. So it is done only in those patients who have got no other options. Without liver transplantation, that person would have died. So with transplantation, now he is able to, 95% of these patients are able to survive. And the changes you want that the thing, yeah?
The donor's life.
Donor's life, actually, I told you, because the donor had got healthy liver, he donated half of his liver, but within 4 weeks, within 1 month, or within 2 months, his liver will grow back. And then he will not have any problem. So he can again take parts in studies and sports and do whatever activities he was doing before. So there was hardly any change in the donor. But in the initial period, once he has donated the liver, so he'll have to stay in the hospital for about 1 week and then maybe do light work for next 1 or 2 months. That's all.
Yeah, can I add something to this? So, while liver transplantation is a viable option, don't be in the belief that it's readily accessible. Only a minority of patients who have end-stage liver disease are able to get a transplant. So don't feel like, oh, if I get sick, I get a transplant. It's not that way. So the best thing is to prevent diseases and prevent progression of the disease.
Good morning, everyone. This is Pratyasha Biswal from St. Joseph's High School. So my question is to Dr. Raj. So what are the symptoms of a liver disease? How can we make ourselves aware that we are going to face a liver disease? Obviously, by test and medical reports, we'll automatically know. But before that, how can we make us aware that we are going to face and we are facing a liver disease?
Great question. Thank you.
So, someone gets to a symptomatic stage, fatigue, where they have abdominal pain, distension, yellow eyes. That's a little too late. So, you can pick up early stages of liver disease through primarily an evaluation of blood tests and obviously examination. Someone may have a big liver, etc. So, regular checkup is the best way of picking up liver disease early. But you get to a symptomatic stage, it might be too advanced. So, something that you need to keep in mind. And you had great education. You understand how you can prevent liver disease. Vaccination is, of course, essential. Have you been vaccinated against hepatitis B?
Yes, sir.
Good, perfect.
Thank you, sir.
Okay, good.
Sir, this is Kirti Subhangi Sahu from St. Joseph's Higher Secondary School. And my question is to Mana sir, that what changes we will notice in our body if we have a fatty liver, and how can we prevent it?
So, very good question. What changes we will notice in our body when we have fatty liver? So, lot of liver disease, unless it extends to that extent, then it will be silent disease. Unless it is going to beyond some extent, and you will have a manifestation like what jaundice and water in your belly, all those things. Beyond that, it is a silent disease. So, what are the changes you will look, and you can suspect you have fatty liver when you are centrally obese. How to know you are centrally obese? So, one excellent method my mentor yesterday he told, you have to measure the length. Length of your hand. Measure this length. Okay, sir. and make it half. Measure this length, arm length, total arm length, and make it half. If that half, let's say this is 6 inch or 150 centimeter, make it half. If and around this your waist, measure this with measuring tape, measure it. If it is more than the half of this arm length, then you can suspect you will have fatty liver. Lot of other parameters are there. आउ किछिटा पैरामीटर अच्छी जेंति की बॉडी मास इंडेक्स जानी छो ना BMI एवरीबॉडी नो BMI किंतु एट टाइम्स हम इंडियन सेटिंग रे देखु छी BMI फेल मारी जाउची व्हाट इज BMI कैन एनीवन से BMI बॉडी मास इंडेक्स हाउ टू कैलकुलेट दैट
kg by meter square.
Very good. So you have to take your weight. तुम ओजन नापिबो weight divided by your height square. तुम हाइट जते अच्छी मीटर ये कर दबो 1.4 मीटर लेट से वहां तार स्क्वायर कर दबो आउ वेट थ्रू डिवाइड कर दबो वेट डिवाइडेड बाय हाइट इन मीटर स्क्वायर देन यू विल हैव ए BMI and you know BMI what is the standard BMI WHO कहे standard BMI आमर 19.5 to 22.5 एटा इंडियन मान को पाई एशियन मान को पाई नो डाउट बाहर लोकों को पाई वेस्टर्न पीपल पाई 25 पर्यंत जाए आमर नॉर्मल 22.5 आज जाई की कैलकुलेट करिवो समस्त निज BMI ठीक अछि वेट देखिबो हाइट देखिबो BMI कैलकुलेट करिवो किंतु सेठी गोटे फालासी अछि गोटे आम इंडियन लोक तार जदि BMI x एंड गोटे वेस्टर्न लोक तार BMI x देखिबो ताहले आम इंडियन लोकर भितरे देह भितरे बॉडी भितरे चर्बीर अमाउंट बेसी देखा जायछि सो ए BMI टा टिके फालासी हो जाउछि टू नो फैटी लिवर और नॉट सो आमे आर्म लेंथ कहली तापरे गोटे मेजर निजर वेस्ट मेजर करिकि देखि परिबो वेट देखि परिबो एवरीथिंग देखि कि तुमे जानि परिबो जे मो भितरे फैटी लिवर अछि कि नै तापर किछिटा स्मॉल टेस्ट अछि जेंति कि अल्ट्रासाउंड कोंती ना सुनि छ ना सेटा देखले हमें जानि पारु जे आम लिवर रे चर्बी अछि ना नै आउ लक्षण जदि कहबो सिम्पटम्स इट जेहेतु फैटी लिवर साइलेंट डिजीज जदि लिवर बेसी पर्यंत खराब हैनी तार सिम्पटम्स आसीबोनी एटा साइलेंट रहबो केते बेले का भा टिके ए राइट साइड जोंठी लिवर थाए आमा केतळे पेन हुए केतळे वीक लागे कि लागे किंतु सिम्पटम्स आसे नि जम
मानस रे वाइंड अप करे पडियो कना 35 टाइम लागे भितरे सो गोटे काम करिया we can start refreshment age अछंती लाइन
sir I have asked to take a selfie so if you come here
सेल्फी तो निश्चय नबा
समस्तंग सहित
मु कोन को रिफ्रेशमेंट से आरंभ कर देबा एठी माने ए जो लाइन अछंती एटा आसंतु माइक रे आंसर दोथुरा से खाऊ खाऊ भी आंसर सुनुथिबे ओके
we'll have a thank you we'll have a group wise selfie with this expert dignitaries school wise पळे आसीबा एंड आम क्वेश्चन आंसर चलथिबो आमे चलिथिबा सेल्फी नै जिबा सेल्फी नेला परे व्हाट विल डू स्कूल वाइज आमे से ब्रेकफास्ट भी आनी की एठी वी कैन हैव अस स्कूल व्हिच स्कूल सेंट जोसेफ स्कूल प्लीज कम सर याडे बुली जा विल हैव ए सेल्फी खाई छो कि नहीं सकालू ब्रेकफास्ट हाँ तुम्हें एठी बुली जा सेंट जोसेफ स्कूल चिल्ड्रन हैव अ लाइन हियर
My question is that why does the liver regrow after transplant?
Why does the liver grow after transplant? ये तो तार कैपेसिटी टू सेल
बोली जा
हेपाटोसाइट
टर्न अराउंड हैव अ लाइन
हेपाटोसाइट सेल्स से रिजनेट करंती से ग्रो करंती सब जगह चमड़ा जेमती सब हमरो जेति की सेल अछि हला ता छोड़ा हम देह रे से क्षमता अछि हम बोन मारू जाई की भी सेल जाई जोटी जोड़ जा दरकार
हैव अ लाइन दैट साइड
सोई पडु जे सेठी ग्रो करि आरंभ करूची आ जोटी जीव जा दरकार से बेले सेल भी हे जीवो ताकू कोनती टोटिपोटेंट सेल से सब ही परिवो हला दरकार हेले बंगाली हे जीवो दरकार हेले ओडिया हे जीवो दरकार तेलुगु हे जीवो
स्माइल एवरीवन
बस जोट जन्म नला तो सेठी का हे गला
थैंक यू सेंट जोसेफ स्कूल थैंक यू St. Joseph School, you go and take your breakfast in a line. Then Stewart School. Stewart School children, please come and have a.
ପିଲାମାନେ ଆପଣମାନେ ଖୁସି ତ?
Good morning, sir.
So in between we can have question answer. If you want to somebody asking question to me, I will convey it to our expert. Stewart School. Stewart School children. Stewart School children. Stewart School children.
Good morning, sir. I'm Akansha
Please
Pradhan.
ask. Please ask.
Good morning, sir. I'm Akansha Pradhan from DAV Public.
Just ask.
Sir, what is the best that one should follow to keep the liver healthy?
So what is the best that we can keep our liver healthy? What is the best thing we can do to keep our liver healthy?
The best thing is, you know what is good food for you by now. So take good food, avoid colas, no alcohol, take vaccine. Vaccine is a must. And then the best thing is, you can do a few tests for hepatitis B, tests for hepatitis B and C.
Slowly, go slowly.
Bhubaneswar. अच्छा को कटक स्टुअर्ट स्कूल रे के दी जन बहुत बड़ा लोग पढ़थले.
So my question.
Very good. So second move.
Dr. S.P. Singh, Subhash Chandra Bose and Dr. S.P. Singh. Clapper. So go in the queue. You know, best healthy रहने पे कौन दरकार? Discipline. So children, be disciplined and have a healthy life. Best of luck to all of you. So next school is Sai International School. DAV Kalinganagar. DAV Kalinganagar people. Come in a queue this side. So go Sai International School children. So in between we can have a question answer. If anybody has question, they can ask. Thank you. Again, discipline for a healthy life. Which school? Which school? Which school? Prabhuji English Medium School.
Good morning, sir. I am Subhait Maunda from Rainbow International School. Sir, I have a question. Excuse me, sir. Sir, I have a question.
Yes, please ask question.
Can anybody's liver be fitted on anybody?
Anybody's liver can it be fitted on anybody? So see, anybody, if you have a fatty liver, it cannot be fitted, mind you. तम भितर प्रति 4 जन भितर जनकर फैटी लिवर अच्छी आजिका दिन में तो से जब बेसी फैट थी ताल हेनी तुम जब रुग्ण लिवर थी हेनी तुम जब ठीक लिवर थी भल लिवर थी सेटा हो पार. So do you know about blood groups?
Yes, sir.
How many types of blood groups you know? 4 types: A, B, AB and O. So do you know about universal donor recipient?
Sir, O.
Yeah, O. So similarly for liver also,
Yes, sir.
O can donate to anybody and AB can receive from anybody.
Sir, everybody's liver size is same or?
Yeah, liver is same for everybody, but it cannot be fit to everybody. So we have to check the blood group and we have to see that the liver is healthy. Only healthy liver can be
Sir, it
checked.
depends upon the blood group.
Yeah, blood group.
Thank you.
So which school?
Rainbow International School.
Rainbow International School. Have a smile. Everyone, please.
Hello.
Thank you very much. Next school. Which school? This is SSBM Dharmavihar. SSBM school, please. SSBM Dharmavihar school. So SSBM Dharmavihar school, can you sit down, because there is a lot of people there also. Sit down for 5 to 10 minutes, then you can have a your breakfast. Very good. Bye. Hi. Thank you. Thank you. Namaskar. So which school this is? Which school? Which school? Which school? Oh, Dharmavihar school. So you can sit down. Thank you. Thank you. Thank you. So this is SSBM Dharmavihar, no? Huh? Ghatikia people, you stay here for a selfie as I have promised, no? We will have a selfie. Have a good 2 lines. You have a session, sir?
No, she has a session. I have a session at 11.
So you can.
Yeah,
you can
4 minutes.
Few minutes.
Yeah, 4 minutes.
Then, okay. So this is for the selfies for SSBM Ghatikia school. Come this side. Come, few people come this side. Very good. Very good. Everyone smile, please. We'll have a smile, everyone. SSBM Ghatikia.
Okay, ready? Okay, thank you.
Thank you, SSBM Ghatikia School. Children, please you sit down for a moment and your teachers will guide you for the breakfast. Sit down for a moment. Next school, plus sit down for a moment. Which school? DAV? DAV Unit 8. DAV Unit 8 school children. DAV Unit 8 school children. DAV Unit 8 school children, come for a selfie. First 2 row कर दिया. हाँ.
Smile, everybody. A smile for healthy liver. So I think last one school is there. You can sit down. You can sit down and we'll have a breakfast. Later on, few people if go. गोटे ओनली वन ना ओनली वन जदि किसी जन को बसाई देले ना दे बसाई देले हां टिके बसाई देले से माने पळे आसी देन देबे व्हिच स्कूल
MBS public school.
MBS MBS na so I think this is last school MBS public school will have a selfie please come Packing Asia. So thank you very much. Thank you, school children. Thank you, our dignitaries and expert. Especially thank you, Dr. Nora. Thank you, Dr. Nora, for coming, giving time and all those things. Thank you, Dr. Raj. Thank you, Dr. Assis. Thank you, Dr. Singh. Thank you, Dr. Sethi. So during taking your breakfast, if you want to ask some question, then also I am here to answer you people. Thank you, Dr. Nora. Thank you. Thank you. Sir, taken your breakfast. Thank you, sir. Sir, चारटा बेले पर्यंत रेडी रहो. हाँ. मु आगु टी काहे के घरे इंटरनेशनल. Very good. अरे आउ कार क्वेश्चन अच्छी किसी अच्छी क्वेश्चन हाँ कह क्वेश्चन कह हाँ कौन सा सस्ता था महंगा था बोलो बोलो आस्क क्वेश्चन थैंक यू सर
Thanks. Nice job.
play more study hard and play more playing not with mobile phones not with TV and mobile phones outdoor games yes football cricket and all those things
During liver tube, right? As Ashish told that we can cut the liver and it gets repaired within 4 weeks. So, sir, when we get liver tumors, so why don't we cut that part?
we can cut that part liver tumor you can cut also at times Enjoyed the session. Taken your breakfast. Huh? How kichi question rahila? No. You know everything about liver. Any amount of alcohol is injurious to liver. No alcohol content. Any amount of alcohol. If a drop of alcohol you will take, that will affect your liver. So no alcohol. No amount is safe. Which one? Cough syrup re alcohol. That is at times we are not taking cough syrup for every day. You are not taking cough syrup every day, na? As and while we are taking that as a medicine.
and that is quite, we can take that, but extra alcohol we should not take. Any amount of alcohol, any amount of smoking is injurious. Huh? Enjoy this side. Enjoyed. Enjoyed session. Huh? And how is food? Fatty liver food, na? Then why you are taking? And you have a choice. You have a choice. You can say, I can take this. This is a fatty liver food or something. Huh? So you are telling you will take the fatty liver food and you will exercise. So it will balance, no? So you have to exercise more. Okay. So is this session helpful for you people? Great. Very good. Which school you were from? Saint Joseph. Where it is? Khandagiri. Ram Mandir. Very good. Which class you people are? 9th class. Great. Very good. Very good.